familiar voice? Okay, my name is Ashley Taliana, and it is a great pleasure to welcome all of you to the Faculty of Medicine, Public Health and Nursing Universitas Gadjah Mada. And it's also my pleasure to be your Master of Ceremony today. And today, it's really honored for me to welcome our distinguished guest, Professor Dr. Yodi Mahendra Datta, Master of Science, Ph.D., FRS, Ph.D. of the Faculty of Medicine, Public Health and Nursing Universitas Gadjah Mada. Welcome, Prof. And also welcome Dr. Dani Pratama Kuswadi, Specialist in Internal Medicine, Kidney and Hypertension Consultant. Welcome, Dr. Dani, as the representing the President Director of Dr. Sarjito General Hospital. And also welcome our esteemed guest lecturer, Associate Professor Shinsuke Akita, MD, Ph.D. from Chiba University Graduate School of Medicine, Japan. And also welcome our speaker today, Engineer Ridwan Wicaksono, Bachelor of Engineering, Master of Engineering, Ph.D. from the Department of Electrical Engineering, Faculty of Engineering, Universitas Gadjah Mada. Welcome. And also welcome to our Chair of the Committee, Dr. Yanto Noviadi Ramli, Specialist in Plastic Reconstructive and Aesthetic Surgery, Consultant in Micro-Oncology. Dr. Yanto, welcome. And also our consultant from Division of Plastic Reconstruction and Aesthetic Surgery, Dr. Ishanono Dahlan, Dr. Rosadi Seswanana. Welcome, Doctor, and also Dr. Aditya Wicaksana. And also welcome all the guests today. Thank you for coming for today's event. And before we start our event today, let's pray together. Pray from our personal, pray begin. Thank you. And starting today's event, let's welcome a greeting from our Chair of Committee, Dr. Yanto Noviadi Ramli, Specialist in Plastic Surgery Reconstruction and Aesthetic, Consultant in Micro-Oncology. Dr. Yanto, the place is yours.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. The Honorable Professor Yodi Mahendra Datta, as Dean of the Faculty of Medicine, Universitas Gadjah Mada, Dr. Dani Pratama, representing the Board of Director of the Dr. Sarjito General Hospital, and also Dr. Rosadi as Head of Plastic Surgery Residency Program, and also the resident, medical student, engineering student, and all participants that join us today. It is my great honor and privilege on behalf of organizing this visiting professor program and guest lectures program to warmly welcome all of you to this special academic event. It is a particular honor for us to welcome Dr. Shinsuke Akita from Chiba University, Japan. Dr. Akita is a plastic reconstruction surgeon whose clinical and academic work has contributed significantly to the fields of lymphedema surgery and also supermicro surgery, lymphatic venous anastomosis, and also breast reconstruction. Today, we are very privileged to learn directly from his expertise and experience through this lecture on latest advances in lymphedema, breast reconstruction, and medical engineering collaboration. We are also very pleased to welcome Mr. Ridwan from Faculty of Engineering, Universitas Gadjah Mada. We will share his perspectives on integrating biomedical engineering with lymphedema and breast reconstruction. Ladies and gentlemen, I believe that today's program is particularly important because it brings together two perspectives that are increasingly inseparable in modern healthcare: clinical medicine and engineering innovation. The challenges we face in reconstructive surgery and lymphedema management are becoming increasingly complex. They require not only excellent surgical skills and clinical knowledge, but also innovation in imaging, maybe instrumentation, biomechanics, robotics, data science, and others area biomedical engineering. And this is where collaboration becomes essential. Surgeons understand the clinical problems, and also engineering can help us to transform the problems into measurable, designable, and solvable challenge. And together we can develop innovation that truly matter to patients. I hope it will generate new idea, new research collaboration, new educational initiative, and perhaps even new technology that can eventually be translated into clinical practice. Once again, Dr. Akita and Mr. Ridwan, thank you very much for being here and sharing your knowledge, experience, and vision to us. Finally, I would like to express my deepest appreciation to everyone who has contributing to making this event possible. And all for the electrician, enjoy this scientific session. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Rianto, for the greeting today. And next, we are going to hear the opening remarks from the head of Plastic Reconstructive and Aesthetic Surgery Study Program, Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, to Dr. Rosadi Seswandana, specialist in Plastic Reconstructive and Aesthetic Surgery, consultant in burn and wound. The time is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, the Honorable our Dean, Professor Yodi Maitra Data. He is my close friend in School of Medicine. We start to study in the 1991. And he is already a professor today in public health. Okay, and the Honorable, the representative of Dr. Sarjito General Hospital Director, Dr. Dani Kwaswadi, thank you very much. He is internal medicine. Our senior, Dr. Sandono, Dr. Rianto, Dr. Adit, and residents. I think that this morning is a great honor and privilege that I welcome you all to this special academic event as the program director of the Plastic and Reconstructive Surgery Residency in this university, Universitas Gadjah Mada. I extend our warmest welcome to our esteemed visiting professor, Dr. Shinsuke Akita. We met in the webinar in education committee of APRAS since 2023, I think. Yeah. From Chiba University, Japan, and also Mr. Ridwan Wicaksono from our neighbor faculty in the north side of the Faculty of Medicine, Faculty of Engineering, Universitas Gadjah Mada. Today we have an invaluable opportunity to learn from two distinguished experts who bring together medicine and engineering in the inspiring interdisciplinary perspective of microsurgery or even super microsurgery. Dr. Yantis already explained what about of the expertise of Dr. Shinsuke Akita and Dr. Ridwan Wicaksono. Yeah. Your presence here represent not only a generous sharing of knowledge and clinical experience, but also a meaningful bridge between our university and our two nations. I am deeply grateful for your willingness to contribute to the education and training of our residents and staff. Through your insight, we hope to enrich not only our academic understanding, but also to strengthen the development of microsurgery services in our education teaching hospitals, Dr. Sarjito Hospital. May this forum become the foundation for lasting collaboration, innovation, and excellence in patient care. To Dr. Akita and Mr. Ridwan, thank you very much for your kindness and dedication. We look forward to a productive and inspiring day of learning together. Welcome, and may this event bring great benefit to us all. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Give applause to Dr. Rosadi. Thank you, Dr. Rosadi. And next we are going to hear the greeting from the representative of Dr. Sarjito General Hospital to Dr. Gani Pratama Kuswadi, specialist in internal medicine, kidney and hypertension consultant. The time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Good morning for our distinguished Dr. Shinsuke Akita and Mr. Ridwan. It's honor for us for your coming today, and I am on behalf of Sarjito Hospital, a President Director. It's my great pleasure and honor to welcome our distinguished from Japan and Engineering Faculty from Universitas Gadjah Mada. We are very pleased to have this valuable opportunity to learn and share knowledge, particularly in the field of plastic surgery. And I think the plastic surgery is a rapidly developing specialty that requires not only advanced surgical skill and technology, but also continuous collaboration, especially with the Chiba University before, like the Dr. Sadi said, and I hope this opportunity we can just not collaborate about just academic, but the facility for the hospital can be a collaboration and innovation, and we have a strong commitment to patient care, and we certainly hope this academic visit will provide an opportunity for meaningful discussion, exchange of experience, and sharing of new perspective between our colleagues from Japan and Indonesia. We believe that international collaboration such as this will strengthen our academic and clinical capabilities, and the most importantly, contribute to better outcome for our patients. I would also like to express my appreciation to the Faculty Medicine and the Dean, Prof. Ph.D. today from Universitas Gadjah Mada, and everyone for involved this important event. Once again, Professor Associated Shinsuke Akita, welcome to Yogyakarta and Sarjito Hospital, and I hope you enjoy your visit and academic discussion today, and warm hospitality from our institution. Thank you very much, and I wish you all, God bless you all. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Dani, for the greetings. And finally, the last but not the least, we are going to hear the greeting from the Dean of the Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, to Professor Dr. Yodi Mahendradata, MSc, Ph.D., FRS, PH. The time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, ohayo gozaimasu, Akita Sensei, Dr. Ridwan, Dr. Rosadi, Dr. Isandono, Dr. Dani, and colleagues from Plastic, Reconstructive, and Aesthetic Surgery. Last month, I had the privilege to attend a meeting in Japan, in Hiroshima, as part of our continuing efforts to strengthen the bridge between Gadjah Mada and universities in Japan. Now, today's guest lecture is also another important step in sustaining those bridges, connecting our shared history with new opportunities in education, research, surgical innovation, and patient care. It is therefore a great pleasure to welcome Akita Sensei from Chiba University Graduate School of Medicine, Dr. Ridwan from Faculty of Engineering, and all of our colleagues joining us today. Japan has been more than an international partner for Gadjah Mada. It has been an important part of our faculty's journey. Over many decades, many of our professors, lecturers, clinicians, researchers have studied and trained in Japan, undertaken collaborative research, exchanged knowledge, and built professional friendship that have endured across many generations. So today's lecture continues that long history of connection while bridging towards the future which is reflected in today's theme, advance in lymphedema treatment and breast reconstruction, which shows that modern surgery must go beyond saving life to restoring function, dignity, and quality of life. Achieving this requires not only sophisticated technology, but also accessible and human solutions developed collaboratively by clinicians, engineers, scientists, rehabilitation specialists, nurses, and patients. So I hope today's event will be more than a lecture or transfer of knowledge. I hope it becomes the beginning of deeper collaboration in education, joint research, technological development, clinical training, and innovations in plastic, reconstructive, and aesthetic surgery, benefiting both countries. So let's honor the long friendship between Japan and Indonesia by transforming this morning into a bridge toward a healthier, more human, and more innovative future. Now, I usually end my remark with a pantun, but I don't know how to write pantun in English. I asked ChatGPT, doesn't look good. So instead, I will end with a brief poem on bridges between Japan and Indonesia. Where Mount Fuji meet the Merapi peaks, two nations listen as nature speaks. Sakura blossom under temperate skies, orchids blossom where warm ocean lies. Separate by seas bound by the sun, through science and knowledge two paths become one. Hand in hand across the Pacific wave, building the future that together we pave. Domo arigatou gozaimasu. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Prof. Yodi. We invite Professor Akita to come forward because we have a bit souvenir for you. Do you want to come forward, please? And we invite all the distinguished guests to come forward to take a photo together and also give this souvenir to Dr. Akita. Okay, please take a photo, smile, 1, 2. Again. Okay, 1 and 2, smile. Is that good? Good? Okay, thank you. Thank you for all the speakers today. Please take a seat. Okay, let's proceed to our main scientific session. And it is really my pleasure to introduce our moderator for today, Dr. Aditya Wicaksana, Master of Science, Specialist in Plastic Reconstructive and Aesthetic Surgery. He is finishing his medical degree in Universitas Gadjah Mada, Yogyakarta, Indonesia from 2010 to 2016, and then continue his education in University College London, London, United Kingdom, and taking Master of Science in Burns, Plastic and Reconstructive Surgery, and graduated with distinction. And then he continued his education in Universitas Indonesia from 2020 to 2025 in plastic reconstructive and aesthetic surgery, with graduated with cum laude. To Dr. Aditya Wicaksana, the floor is yours.
Okay. Assalamualaikum warahmatullahi wabarakatuh. Thank you very much for the introduction, Dr. Lily. Good morning, distinguished guests, professor, respected colleagues, resident students, and all joining us here and online. It's great pleasure and privilege for me to moderate today's academic session. My name is Aditya Wicaksana from the Division of Plastic, Reconstructive and Aesthetic Surgery, Department of Surgery, Faculty of Medicine, Universitas Gadjah Mada, Dr. Sarjito Hospital. And today is quite special for us. After many months of communication and preparation between Indonesia and Japan, finally we have the opportunity to welcome our distinguished guests here in Yogyakarta. Dr. Akita, once again, welcome in Yogyakarta and Universitas Gadjah Mada. We are truly delighted to have you here. So the theme of today's program is Bridging Japan and Indonesia Through Surgical Innovation, Latest Advances in Lymphedema, Breast Reconstruction, and Medical Engineering Collaboration. And like what Prof. Yodi already mentioned, I think the word bridging captures very well what we hope to achieve today. Bridging surgery and engineering, bridging innovation and patient care, and hopefully we can also bridge Chiba University and Universitas Gadjah Mada. Before we begin, one brief note regarding the discussion. So throughout both presentations, you may submit your questions through Slido. And for those in the room, of course, you can ask directly. And we will also take questions from participants from Zoom. And we will bring these questions together during the second lecture. Okay, so ladies and gentlemen, it's my great honor to introduce Dr. Shinsuke Akita from Chiba University, Japan. So Dr. Akita is an associate professor in Department of Plastic, Reconstructive and Surgery at Chiba University Hospital, and also director of the MedTech Link Center. His main interests include lymphatic surgery, supermicrosurgery, breast reconstruction, lymphatic imaging, regenerative medicine, and medical engineering collaboration. And what we particularly appreciate is his enthusiasm for strengthening the collaboration between Japan and Indonesia through research, education, academic exchange. Dr. Akita, thank you very much for being with us today. Before we begin, one brief reminder, some parts of Dr. Akita's presentation may contain confidential or unpublished material. So we kindly ask everyone here and online not to photograph, record, or share any material identified as confidential. Thank you very much for your understanding. Ladies and gentlemen, without further ado, it is my pleasure to invite Dr. Akita to deliver his guest lecture, Translational Innovation in Surgical Science, Latest Advances in Lymphedema, Breast Reconstruction, and Medical Engineering Collaboration. Dr. Akita, the floor is yours.
No, thank you. Maybe. Now extend the view. Okay. Ada di Java. Okay.
Okay. Okay. Again, Jim, thank you for introducing me and how I'm very honored to be here. Thank you for Professor, all of attendees, inviting me to Gadjah Mada Hospital, University, having the great symposium. I'm very honored to be here. I'm really looking forward to meeting all of you today. My title is Bridging Japan and Indonesia through Surgical Innovation, Latest Advances in Lymphedema, Breast Reconstruction, and Medical Engineering Collaboration. They are areas with my field of experience, and I believe they are areas that we can further develop through collaboration with all of you. First, let me introduce myself again. I'm belonging to Department of Plastic, Reconstructive, and Aesthetic Surgery, and I'm also a director, Medtech Link Center, Chiba University, Japan. Actually, August 31st, today is my birthday. Just today, I became 50 years old. For this reason, I don't think I'll ever forget where I was and what I did on my half-century anniversary today. Let's make today a wonderful day together. My specialty ranges a lot. Clinically, the most important field I have worked is lymphedema. I have also treated a lot of cases of orthodox breast reconstructions. Since keloid are more common among Japanese people than among Caucasians, we have been working on this issue. However, since both Japan and Indonesia and in Asia, keloid has becoming a very important issue compared with European and in USA. So I'm focusing on basic research about keloid. So today I'll introduce some of my works about keloid too. Recently, I've been working more frequently with the director as a director of the Medtech Link Center, and translational research and medical device development are also areas of my expertise now. I'm arrived on this island for the first time yesterday and visited the Borobudur Temple with my family. I'm deeply honored to have the opportunity to lecture in Yogyakarta, a city with a truly wonderful tradition, and at the Gadjah Mada University. Just now, in our department, an Indonesian student conducting lymphedema research. She will also visit A+ Congress in Bali from day after tomorrow. I believe she will help you when you will visit Japan in future. She will bring us. Now, let's get down to today's business. Yep. This slide outlines the agenda for today's talk. The first topic is what is needed for innovation in plastic surgery. I will discuss what plastic surgeons in Japan are doing and what challenges they face. Next, I will discuss lymphedema, my area of expertise. In detail, I will cover various aspects of lymphedema, including surgical treatment of lymphedema, clinical research, basic research, and clinical implementations. The third topic is scarlet surgery. I will focus primarily on breast reconstruction and keloids. For breast reconstruction, I will discuss the use of endoscopes and robotics maybe. And for keloids, I will cover basic research. I build the final chapter 4 as more of discussion than a traditional lecture. I have titled the Tabard Collaboration between Japan and Indonesia in plastic surgery research. I'm not familiar with the specific circumstance of plastic surgery in Indonesia. After listening to my lecture, I'd like to hear your opinion on area and research topics where I believe we can collaborate in future. Okay, so let's move to the first topic. What is needed for innovation in plastic surgery? And classical plastic surgery has been developed by reconstructing forms and function. This is one of the principles of plastic surgery. The fields of plastic surgery range large, including traumas such as facial bone fractures, malignant tumors such as breast cancer, and congenital anomalies such as cleft, and degeneration diseases including thyroid eye. Since all of these patients are my own patients, and a plastic surgeon must possess a wide range of skills. Furthermore, because every patient is different, we must learn from each and every case. Plastic surgery is highly individualized, and decisions are based on the surgeon's experiences. So we should learn how to improve each patient one by one. For example, this slide shows a case with nose defect following resection of squamous cell carcinoma. Reconstructive strategy was planned based on individual defect deformity. Do you see under what kind of surgery? How about your plan? Okay. My answer was expanded median forehead flap combining another flap and grafts. We used nasal mucosal flap for lining and limb cartilage for frame and median forehead flap for cover. In addition, we also use temporal fascial flap as a free flap also as a lining, in this case for lining. After the corrective surgery, this patient was able to fly on airplanes and travel abroad without wearing any mask, resulting in a very favorable outcomes. She has become happy. To study each of the cases is really important for plastic surgeons. PRS Go promotes video content, and I contribute to this program. Oh, let's see one of our video. Oh, you cannot hear the. You cannot hear the sound. Can you? I think. Oh. You cannot hear. Sorry. But you can see this video online in PRS Global Open, so let's check it later. Okay, let's move to my presentation again. Okay, let's move to next. This video shows the facial nerve schwannoma cases, and so we use tissue expander. Okay, no problem. To date, the field of plastic surgery has sought to improve treatment outcomes by developing new surgical techniques tailored to specific challenges. Supermicro surgical LVA for lower extremity, the right image of this slide. It also a technique which is spreading all over the world now. Reconstruction using tissue. Okay. No, you can't see this video. Okay. No. Okay, supermicrosurgery for lymph node is a relatively new field. We have been refining the technique. However, until now, we did not standardize the technique, and surgical procedures in this area. Sorry, but my laptop works bad. My laptop does not work well. I can do it. Sorry. I would like to discuss the challenges in plastic surgery that we are currently considering. First, limitations of improvement for surgical treatment performental tissue. Degeneration has highly progressed. Rate of lymphatic flow restoration following reconstructive surgery for postoperative upper limb lymphedema after breast cancer surgery is only 70%, less than 70%. Even when highly invasive surgeries are performed, there are cases where good treatment outcomes are achieved and cases where they are not. Although the deep flap is designed to place the scar as low as possible, in breast reconstructive surgery, but the scar is sometimes very tight and noticeable, causing significant decreases to the patient after surgery. Third, conditions that remain difficult to control. The recurrence rate following multidisciplinary treatment of keloids range from 10 to 30%. This slide shows keloids that recurred following excision and radiation therapy. 2 years later, triggered by pregnancy, as you can see, it grown even larger than the original keloid. I think plastic surgery needs to evolve from expertise-based individualization to data and pathology-based individualization. In many surgical specialties, precision medicine has been developed by building evidence starting from standard first-line approaches. In contrast, plastic surgery has traditionally evolved as a highly individualized field with decision based on expertise. However, in the future, plastic surgery will also require standardization based on objective data and through standardization by disease state. I believe plastic surgeons should also aim for new precision-based medicine. I serve as a director of the Medtech Link Center at Chiba University. What is this? Medtech Link Center can connect clinical needs with technological innovations. This division bridges not only the Department of Plastic Surgery, but also various other departments. It connects clinicians and basic researchers, medical researchers with engineering researchers, and healthcare professionals, and industries and companies. As an example of clinical research, basic research, and lots of fields, I will discuss the following topics related to lymphedema. Let's start lecture about lymphedema. My most specialized disease is lymphedema. As the current understanding of the condition of this disease, its pathology is lymphatic stasis leads to proliferation and fibrosis of the subcutaneous tissue. The important problem of the patient is recurrent cellulitis, which significantly impairs QOL. Lymphedema is classified into primary lymphedema, such as congenital or age-related forms, and secondary lymphedema, which primarily occurs following cancer treatments. Lymphedema is more than fluid accumulation. Lymphatic stasis drives chronic inflammation, lymphatic dysfunction, and tissue fibrosis. We believe that the accumulation of lymph fluid causes inflammation, which leads to tissue fibrosis and inhibits the lymphoangiogenesis. Surgical treatments for lymphedema ranges a lot of techniques, the volume reduction and reconstructive techniques. Volume reduction includes liposuction and surgical resection. Reconstructive method includes lymphovenous anastomosis, LVA, and vascularized lymph node transfer, VLNT. In Japan, surgical treatments for lymphedema are indicated for more than 60,000 cases per year, and LVA accounts for 90% of surgical treatments for lymphedema. In lower extremity, volume reduction surgeries are also indicated, but the number of far smaller than LVA. To ensure that lymph fluid flows antegrowth into the veins, appropriate indications and therapeutic strategies are essential. Lymph fluid must flow smoothly and through the bypass from the lymphatic vessels towards the veins. So, contraindication, there are some contraindications to LVA. Very small amount of lymphatic flow and very high pressure of the veins. These cases, LVA cannot work well. For patients who are candidates for surgery, it is also important to determine at what level of the extremities to make the skin incision to create the bypass. It is necessary to target areas where lymphatic flow is as good as possible and venous pressure is lower the closer the site is hurt. The optional anastomosis site must be determined on the case-by-case basis for each patient. Even when patients do not have obvious chronic venous insufficiency, minor venous abnormality may still exist. Therefore, ultrasonography is primarily important for screening for venous abnormalities. This slide shows a case with micro-arteriovenous fistula in the leg. This should be detected before surgery because venous pressure is very high. In this kind of cases, we indicate a ligation of communicating veins between the superficial and deep venous system combined with LVA. This can reduce the venous hypertension and improve the dynamics. Okay. We perform various kinds of anastomosis, yet end-to-end, side-to-end, and lots of kind of anastomosis, depending on the cases and the locations of the lymphatics and the veins. We make lots of anastomosis to prevent venous reflux to one venous system from lots of lymphatic system. Multiple LVA to single venous system is especially important to prevent venous reflux after surgery. When we notice the power of anterogrowth flow is weak, we add lots of LVA to one venous system. Therefore, both multiple LVA is very important to overcome the venous pressure by lymphatic flow. Now, I'm performing side-to-end anastomosis again. Side-to-side anastomosis this area. The last time we will check the flow by ICG lymphography, so the lymphatic flow defeats the venous pressure. You can see. Oh, I add one more anastomosis from lymphatic stump to the side wall of the vein. In this case, I guess 4 or 5 anastomosis to one vein. So we can see the lymphatic flow defeats the venous flow in this case. Anterogrowth flow is the most important thing. Okay, LVA can indicate it for both upper and lower extremity lymphedema. In the lower extremities, bilateral lymphedema may occur. In such cases, it is difficult to tell by appearance alone whether the patient has gained weight, if the lymphedema has worsened. So it is necessary to check the function of lymphatic flow by testing. Each modality for evaluating lymphedema has its own characteristics. Currently, the most commonly used tests for lymphedema include ICG, fluorescent lymphography, ultrasonic sonography, and lymphoscintigraphy. Each modality for evaluating lymphedema has its own characteristics and has recently innovations. You can see the movie of later. I'll show later ultrasonography video. Spectroscopy is a fusion image combining lymphoscintigraphy and CT imaging. Profits of this method is deep tissue visualization and quantitative assessment. Disadvantage of this method is painful by injection and radiation exposure. Quantification enables objective assessment of lymphedema, gaining a detailed understanding of this information and where lymph accumulates may be useful in determining the site of skin incision and evaluating postoperative recovery. It is important to identify lymphatic vessels that are proximal and have high flow volume before surgery. ICG lymphography has become widely used around the world in recent years because it's a less expensive way to check the lymphatic function. Inexpensive and innovation, no radiation exposure, but only the superficial lymphatic vessel can be observed using ICG lymphography. ICG can detect early abnormalities before the onset of symptoms. In addition, since the initial presentation changes as the condition progresses, it is impossible to classify the severity of some extent. Since ICG lymphography can detect abnormalities before there is a noticeable increase in the volume of the limb, it may be useful for early diagnosis of lymphedema. Detecting subclinical lymphedema using ICG leads early treatment. Early treatment is very effective for the patient. In our case series, following early LV treatment, compression therapy was discontinued in 45% of the cases. In the presenting case, abnormal findings on ICG lymphography was diminished after LVA, and she became free from compression therapy. In this case, she has left upper extremity lymphedema, and she cannot use compression therapy because she was a suffer. So ICG findings became completely normal after LVA, and but the surgery allowed her to maintain her lifestyle. She continues suffering, and she never wear any compression. She could continue her own lifestyle. We use ultrasonal frequency ultrasonography with 46 MHz probe to visualize the evaluated lymphatics. Compared with ICG lymphography alone, ultrasound provides much more anatomical details. You can see the high resolution of the 46 MHz ultrasonography. To prevent venous reflux at the site of LVA, it's essential to identify lymphatic vessels suitable for anastomosis. Preoperative ultrasound sonography is very useful to detect the lymphatic vessels with high internal pressure. Left image shows the growing lymph node with dilated lymphatics, and the right image shows the dilated collecting lymphatics in the forearm. Dilated collecting lymphatics can be seen directly, and we can check the size compared with the small veins. This table shows the correlation of ICG diameter cross stage and lymph node size and efferent lymphatic diameter using ultrasonography. In ICG diameter cross stage 0, both lymph node and efferent lymphatics is larger than normal level, so we can indicate LVA with ease in this area. They have very strong pressure. In early stage lymphedema without severe lower limb obstruction, the inguinal efferent lymphatic vessel is a favorable target for LVA. In this level, venous pressure is very low because close to the heart. In the limbs, lymphatic trunks are typically observed just beneath the superficial fascia using ultra-high frequency ultrasonography. This anatomical understanding is very important during surgical planning. We evaluate the confluence and obstruction, narrowing, and tortuosity of the lymphatic vessels. Based on these findings, we determine the optimal incision site for LVA. This is one of the major advantages of ultrasound-guided surgery. Let's see the movie. Okay. Oh, too fast. Again. We can see the confluence point and obstruction point, or abrupt narrowing point, or a tortuosity point with irregular luminal diameter using ultrasound. The size of these corrective lymphatics is about 0.5 millimeter. The use of ultra-high frequency ultrasonography enables anastomosis at the site with high blood flow. In this video, after 2 lymphatics coverage, they become obstructed slightly proximally. Let's see. They confluenced and obstructed. We can make skin incision here. Let's see the surgical video. During surgery, we found that just proximal to the confluence point, we can see the obstructed point. I'll cut the lymphatic again, and you can see the 2 holes in 1 lumen. This is a confluence point. At this area, the lymphatic flow is very high, so the lymph is washed into the vein after anastomosis wear. Long-term patency rate is very high in this kind of lymphatics. We conducted a study to investigate the relationship between dermal backflow observed ICG lymphography and the location of abnormal findings detected by ultra-high frequency US. Early dermal backflow transition point, EDBFTP, was observed in ICG lymphography like this. Now, I'm checking the dermal backflow point. This is not a dermal backflow. This is a stasis. More proximally, we can see the dermal backflow point in ICG, a yellow arrow. This is a point dermal backflow starts, the most distal area of the leg. And we check this point by red marker. To record the ICG findings like this. After that, we use ultra-high frequency US and check the morphological changes of the lymphatics. And we analyze the spatial relationship between early dermal backflow point and ultra-high frequency US abnormal findings point. We found that confluence, narrowing, and obstruction points were located more proximally than the early dermal backflow point. So confluence points and early dermal backflow points may function as bypass around the obstructed. And now those segments combine ICG lymphography and the US. We can detect the most high pressure point in the lymphatic lumen here. So Before surgery, we should detect the most high pressure point of lymphatics using both ICG and US. Based on this finding, we can detect the most appropriate point for anastomosis. Lymphatic vessels with high internal pressure have greater ability to wash out the veins. This slide shows a high flow lymphatic vessel dilated to a diameter of 1 millimeter. 1 millimeter is very large as a collecting lymphatic and a very high flow. I introduce you another intraoperative tool to detect the lymphatic obstruction point, lymphatic wire. For deep lymphatic vessels, 0.12 inch lymphatic wire, which is about 0.3 millimeter, is often useful. Lymphatic wire is inserted under the microscope via the lateral wall window. Under the microscope, we can insert the wire into the lymphatic, and the intraoperative ultrasonography can visualize the wire from skin surface. This helps confirm lymphatic continuity and obstruction point too, but a little technically difficult to control the wire. The lymphatic wire can also facilitate anastomosis using a stenting technique. Another treatment method for lymphedema involves harvesting lymph node flap and the blood vessels that supply them from healthy parts of the patient's own body and transplanting them into the affected area, vascularized lymph node transfer. It's believed that new lymphatic vessels form at the transplanted point, which helps the transplanted lymph nodes improve lymphatic flow. There are several candidates for the donor site for VLNT, but they are not standardized yet. This slide shows the case of VLNT from supraclavicular region to left side. This case underwent VLNT from mandibular to the groin. She also underwent abdominoplasty simultaneously and became very better. There is still no consensus for donor site for VLNT. Advanced stage breast cancer-related lymphedema with severe axial scar can be improved by VLNT. In this case, after severe scar was released and radiation also was reconstructed by a free tap flap, including lymph nodes from left side, the volume of the right upper extremity reduced, ulceration cured, and the chronic inflammation improved. VLNT can be combined with breast reconstruction. This slide shows a case who needs a delayed breast reconstruction and treatment for upper limb lymphedema. For this patient, deep flap, including growing lymphatic system, was elevated and transferred. Improvement in both in breast aesthetics and upper extremity lymphedema was made. Okay. Our mouse experiments showed well-vascularized lymph node is essential to restore lymphatic function, so please be sure to anastomose the blood vessels that feeds the lymph nodes to be transferred. The biggest concern with VLNT is complication of lymphedema in the donor site. Donor site lymphedema should be prevented surely. Prevention of donor site lymphedema is a very, very important thing. In our institution, we perform ICG lymphography to visualize lymphatic flow from the lower extremity as a reverse mapping to prevent the donor site lymphedema. After that, patient patent blue dye was injected to the visualized lymphatic flow from the lower abdomen. In this way, only lymph nodes that receive lymphatic flow from the lower abdomen can be selectively included into the flap. So, lymphatic flow from leg was preserved. So, breast reconstruction plus growing lymph nodes can be performed by both deep wrap and skip wrap, because skip wrap is indicated mainly for the patients following breast conserving surgery, because the size volume of skip wrap is relatively small. Today, I'd like to talk about deep wrap plus BNT following mastectomy. To determine the design of the deep wrap plus BNT, appropriate balance of lymph node location and breast morphology is essential. We have mainly two design patterns. For large breast, ipsilateral DIA and SCIA are used as a vascular pedicle, and the skin pad is located vertically placing zone 3 cranial. In the patient with small breast, ipsilateral DIA and contralateral SCIA was used, and the skin pad is placed by turning 180 degrees upside down. The design is very important to make aesthetic breast and good location of the lymph node. Skin pads are often designed to slightly separate compared with normal deep wrap in order to balance the position of the lymph node and the breast mound. Colored plasmography is performed to map blood vessels and lymph nodes preoperatively, like this. ICG lymphography is also performed preoperatively to know the lymphatic flow from the lower extremity as a reverse mapping to prevent donor site lymphedema. Blue dye is injected after flap design just before skin incision to verify the lymphatic flow in the elevating flap. You can see the blue dye to know the lymphatic flow, and you can see the lymph node. This video shows the growing lymph node transport by the superficial branch of the right SCIA. SCIA and the V should be dissected to be anastomosed with lateral thoracic artery and vein or serratus anterior branch of the thoracodorsal artery and vein later. This is a lymph node. Now dissecting the lymph node wrap and vessels. This vessels is anastomosed to the axillary branches. No? Okay. Next, we should check the blood flow of the transfer elevated wrap. No. This video does not work. Sorry. The blood flow range of the flap is determined by ICG angiography as in a normal deep flap. It is classified into early stained area, delayed stained area, and no stained area in ICG angiography. ICG angiography of multiple perforated deep flap combined with growing LNT was seen in this video. It worked? Okay. I check the early stained area and the delayed stained area, and also check the blood flow of the lymph node for reference. But it is better to anastomose SCIA and V to the axillary blood vessels in all cases, regardless of whether lymph nodes are enhanced by ICG lymphography or not, ICG angiography or not. The shape of the skin pad, the amount of adipose tissue, and the length of the lymph node flap are determined according to the needs for the recipient. The length of SCIA and V should be enough to be anastomosed with vessels on the donor site. Very long harvest is important. This slide shows the right breast and right axilla. DIA, V were anastomosed to IMA and V. SCA and V were anastomosed to the thoracodorsal A and V, TDA and V. The direction of lymphatic flow in the lymph node flaps should be aligned with the lymphatic flow from the upper extremity to facilitate the lymphoangiogenesis after surgery. Occasionally, we can confirm the bridging the lymphatic flow between the recipient and the BNT by ICG lymphography. This bridging of the lymphatic flow is very important to improve the symptoms. Ultrasonography is used to observe long-term functional survival of the transferred lymph nodes. We compare the clinical results of BNT with and without breast reconstruction. And we found that the number of patients who could reduce compression therapy was significantly larger in the group of BNT plus DPRAP compared with BNT without breast reconstruction. This slide shows a case with a primary lymphedema treated using growing BNT. In primary lymphedema cases, contralateral side can be checked by ICG lymphography and scintigraphy as a candidate for donor site. This slide shows ICG macrophage and pathological changes in lymphedema. As the function declines, fibrosis of the skin and the subcutaneous tissue progresses. Ultrasonography can be used to evaluate the degree of fibrosis in lymphedema. Lymphatic capillary degeneration progresses in advanced lymphedema. In advanced stage lymphedema, the lymphatic capillaries are unable to absorb extracellular fluids, so in these cases, liposuction or surgical excision may be combined with microsurgical treatments. Debulking surgery should be performed in this kind of advanced cases. In cases with very severe lower extremity lymphedema with severe fibrosis, lymphatic microsurgery plus debulking surgery can be indicated. Severely fibrotic tissue should be, and the skin should be removed, resected, and LVAs performed after that. In our experience, optimal outcomes are achieved through a combination of complex deconstructive therapy, which means conservative therapies, and surgical treatments are combined with them. Especially in the patients with advanced stage lower extremity edema, conservative therapy, microsurgical reconstruction, and when necessary, reductive procedures should be effectively combined. Surgery alone is not enough. Compression therapy remains essential even after surgery for life day long. This slide shows lower limb lymphedema and inadequate conservative management. We determined resection and anastomosis site based on imaging using SPECT-CT. After surgery, psoriasis no longer occurred while continuing compression therapy. SPECT-CT shows increased lymphatic flow on SPECT-CT after surgery. We begin compression immediately after surgery. Why is that? Immediately after surgery, we start compression therapy because an increase in lymphatic pressure and the dilation of the lymphatic spaces are observed immediately distal to the site of obstruction. LVA decreases the pressure in the lymphatic vessels. Compression promotes both venous and lymphatic flow towards the heart. Anterior flow through the anastomosis is maintained. So compression is necessary to keep the lymphatic the flow from lymphatic vessel to vein. LVA decreases the pressure in the lymphatic vessels. Compression promotes both venous and lymphatic flow. LVA with our current LVA strategy combines three elements: prevention of venous reflux, intraoperative assessment of lymphatic anatomy and flow, and immediate post-operative compression. In our study, dermal buccal decreases in 46% of the patients, and these patients showed greater improvement in quality of life. So far, I have discussed the treatment after lymphatic dysfunction has developed. The next question is whether we can interpret intervene even earlier, ideally at the time of cancer surgery itself. Immediately reconstruction can be performed for preventing lymphedema. Immediate lymphatic reconstruction, or ILR, has attached considerable attention. A recent meta-analysis reported the lower incidence of lymphedema after ILR. However, an important question remains. Is ILR superior to careful surveillance, conservative treatments, or early LVAs? Early intervention does not necessarily have to be surgical. This randomized study showed that early physiotherapy significantly reduces the risk of lymphedema. Prevention therefore requires us to compare several different strategies, not surgery alone. In our own cohort, early LVA for subclinical lymphedema showed a high remission rate with long-term durability. This was particularly striking in the upper extremity, where patients who discontinued the compression remained compression-free during long-term follow-up. This brings us to another concept, lymphatic vessel regeneration for preventing lymphedema. One approach is subcutaneous implantation of the nanofibrillar collagen scaffold, which has been proposed as a matrix that may support lymphangiogenics. This was developed in Stanford, and in Japan we cannot do this clinically, so we start from basic research. Our question was very practical. This scaffold does not require advanced microsurgical skills and can be implanted quickly during lymph node dissection. So we asked whether immediate implantation before pathological tissue changes develop might be more effective than the delayed treatment. This work was conducted by Jocelyn Kadaman from Indonesia to our department. We therefore designed a hindlimb lymphedema mouse study comparing no scaffold, delayed implantation of scaffold, and immediate implantation of scaffold. Our hypothesis was that once inflammation and fibrosis develop, the regenerative effect of the scaffold will be reduced. We used the sprinted hindlimb lymphedema model with the inguinal and popliteal lymph node resection. The collagen scaffold was implanted through the subcutaneous tunnel to create a potential pathway for lymphatic regeneration. We evaluated the model using micro-CT, volumetry, and ICG lymphography for the mouse, together with histological and molecular analysis. First, we confirmed successful establishment of the lymphedema model. By day 10, the operated limb showed significant epidermal and dermal thickening compared with the contralateral limb. Lymphatic morphology also changed. The affected hindlimb showed fair lymphatic vessels with the dilated and irregular morphology, whereas the control side retained smaller and more regular lymphatics. Mass spectrometry stain and molecular analysis demonstrated increased fibrosis in the affected limb. This confirmed that pathological tissue remodeling was already developing by delayed treatment time point. With the model established, we proceeded to the main comparison among the NCS, no NCS, dead NCS, and immediate NCS group. Immediate implantation accelerated edema resolution. At day 10, 21, and 28, here volume changes were significantly smaller in the immediate group than in the untreated and delayed group. ICG lymphography shows the same direction of the effect. Immediate NSS implantation produces better recovery of lymphatic function. Histologically, immediate implantation also reduces the dermal thickening. This suggests that early restoration of lymphatic pathway may suppress secondary tissue remodeling. The immediate group showed less fibrosis-related gene expression and better preserved organizing collagen architecture. Again, timing approaches to matter. Importantly, the immediate implantation group also showed higher lymphatic vessel density. This supports the concept that the scaffold can promote lymphatic regeneration when implanted before advanced tissue degeneration develops. Immediately is the best for implanted. When we examine the scaffold itself, lymphatic vessel density within the NCS was significantly higher after immediate implantation than after delayed implantation. Electron microscopy provided a striking image of this process. In the immediate group, we observed abundant newly formed lymphatic structures, lymphangiectasis within the collagen scaffold in immediate group. A mouse model, therefore, suggests that immediate implantation may be superior to delayed. Immediate implantation is superior to the delayed implantation. Of course, animal models have limitations, and the next step is clinical validations. This work was led by my student from Indonesia. I'm thanks to her. Putting these findings together, our prevention strategy has 3 levels: simple immediate reconstruction, postoperative education with non-invasive monitoring, and early LVA when subclinical or early stage disease is detected. Okay, next we should introduce Dr. Masahiro Takei, Professor of Engineering. This work also connects directly with engineering research at the Chiba University. My friends, Professor Masahiro Takei leads a highly international laboratory with researchers from Indonesia and many other countries in the field of engineering. And with backgrounds ranging from mechanical and electrical engineering to biology and computer science. I have developed a novel diagnostic tool for lymphedema with them, including Dr. Wicaksono. Now, I would like to introduce electrical impedance tomography, or EIT. This technology is central to our collaboration with Professor Dr. Takei. The basic idea of, I'm not familiar with this field, but I read this. I make an effort. The basic idea of tomography is familiar with from CT imaging. We reconstruct an image of the inside of the object from measurement made around it. Electrical tomography uses electric signals rather than X-rays, making the system potentially smaller, faster, and much less expensive. Electrical tomography, EIT, has application far beyond medicine, including industrial plants, chemical reactors, microchannels, and lots of industry. Okay, stop. Okay. EIT research requires several components: understanding tissue electrical properties, electrons and electronics, sensitivity modeling, image reconstruction, and finally image interpretations. Our team integrates expertise across all of these steps, but I'm not familiar with this. I'm a clinician because this video demonstrates the principle of EIT. You can see that where this was placed using EIT, like this. And this video shows how to measure the limbs to check the edema. After adding the pressure on the side to induce the edema. After that, the finding will be changed immediately. We can see the changes. We have progressed step by step from cells, phantoms, to healthy volunteers, and now patients. I will briefly show you where we are today. In healthy subject, we demonstrated the dynamic visualization of conductivity changes related to the intestinal fluid and albumin distribution in the subcutaneous fat layer. The goal is four-dimensional monitoring, three-dimensional space plus time. This technology is now being transferred toward clinical use through TomoCloud company. The goal is a non-invasive tomography specialty designed for new lymphedema care and new lymphedema evaluations. Current lymphedema assessment uses several modalities including tape measurement, bioimpedance, ultrasonography, ICG, scintigraphy, CT, and MRI. It is useful, but none is perfect for simple, frequent, objective monitoring. Our goal is a system that is accurate, non-invasive, and easy to use. We envision both a hospital device for objective assessment and a personal device that could be help monitor patients between clinical visits. We have already completed the clinical study in 30 patients at Chiba University Hospital. The company has now raised approximately 30 million yen, or about 1.9 million US dollars, and we are planning a physician-led clinical trial from next winter. Our future vision is to connect prevention, non-invasive monitoring, and early treatment. If EIT can identify early tissue changes before advancement of lymphedema develops, it could become a game changer in lymphedema management in future. And this is where I especially hope Japan and Indonesia can work together. Lymphedema is a global problem, and collaboration across Asia can accelerate both research and implementations. Okay. I finished lymphedema now, and it's, we have a lot of times yet. Okay, next, let's move to as a next topic is scar surgery. This is also important for Asian compared with Caucasian because our scar is very visible. I will talk about breast reconstruction and keloid. Our recent innovation in breast reconstructions is scar surgery. Not only did our paper make the cover of PRS, but it was also selected as the promotional illustration for the 24 issues of PRS itself. The term scar surgery can mean different things between general surgeon and plastic surgeon. General surgeon often aim to minimize or hide the excess scar, while plastic surgeon also think about biologically minimizing scar formation itself. I believe these two concepts can be integrated. Both is very important. So based on this idea, we developed a minimally invasive breast reconstruction procedures using subcutaneous endoscope and extended latissimus dorsi flap. I will introduce this method by video later. For patients with a relatively large breast who also benefit from abdominoplasty, the deep flap remains an excellent option. It is versatile for immediate or delayed reconstruction, and for different abdominal conditions, deep flap is very useful for the patient who needs abdominoplasty. For patients with smaller breasts and thick abdominal wall, we also developed techniques for partial thinning of the deep flap to improve the breast symmetrically without excessive volume. However, donor side well-being matters. Previous breast Q data suggests that patients with excellent preoperative abdominal well-being may experience a greater perceived decline after deep flap harvest. This is especially relevant with abdominoplasty. It is not desired. We previously tried to reduce this problem with a low-rise abdominal scar. Even so, some patients continued to complain about scarring or abdominal tightness after surgery. This is very problematic for patients QOL. The same problem exists with conventional latissimus dorsi flap. Once a patient has a long back scar or persistent tightness, these complaints can be difficult to treat. Adding lipofilling to LV flap can increase the reconstructive volume. This combination gave us the opportunity to reconsider how the LD flap could be harvested with much less donor site scarring. We therefore developed the endoscopy-assisted extended latissimus dorsi flap, or EELD flap. The key concept is to harvest the large muscular adipose flap without conventional back skin incision, leaving only small drains or port sites, small incision. The procedure uses standardized endoscopic instruments, forceps, and ultrasonic dissection devices, monopolar device, and rigid endoscope. Importantly, these instruments are already available in many hospitals because they are used in general surgery departments. Before surgery, we map the vascular anatomy using color Doppler ultrasonography. This helps us identify the thoracodorsal system and the adipose tissue territory that can be safely included with the muscle. This is the operating setup during elevation of left EELD flap. The operator using both hands while a camera assistant and another surgical assistant supports the endoscopic dissection. Here is the elevated EELD flap. A relatively large unit of muscle and adipose tissue can be harvested through the mastectomy incision without creating a long back scar. This video demonstrates the key steps of EE flap elevation. Elevation of the abdomen flap and the muscle flap was performed from the skin incision at the site of the postoperative scar of the mastectomy. When the mastectomy skin incision is very large, we start with under direct vision and includes the adipose tissue to the flap, and so those dragon's nerve was cut and removed. So those arteries and veins were marked using a Bessel tape. The subtendon tissue was dissected under direct vision. And the porthole was made and inserted. These ports were used for camera and instruments. The port on the most cranial side was placed at the edge of the skin incision. We first performed dissection around the port incision site endoscopically to increase the working space. Under the endoscopy, we dissect the adipose tissue and the muscle, 2 layers under the muscle and above the muscle. The assistant applies a nylon thread to the back skin under the supervision of the operator. We also use CO2 insufficiency to make the space. Inflate the CO2. Ultrasonic coagulation dissection system was used to stop bleeding and seal blood vessels. This device is a little expensive. After the placement of the drain, the patient was placed in the supine position and the flap was transferred. When combined with less than 100 millimeters of live filling, this flap can reconstruct selected breast below approximately 350 milliliters. In this example, reconstruction was completed without a conventional donor site scar, without leaving any scar on the back. We use a three-dimensional photogrammetry to measure the breast volume objectively after surgery. This allows us to follow postoperative volume changes over time. In our first 15 cases, reconstructed breast volume decreased to approximately 70% of the initial postoperative volume by about 8 weeks and then reached the plateau. Additional live filling was required in 7 patients of the cases. When we compared EELD flap with conventional LD reconstruction, breast satisfaction was similar, but satisfaction with the back and the back-related well-being were significantly better with the patient with EELD approach. This is a delayed reconstruction case using a tissue expander. A second lipo-filling session was performed at the same time as a nipple areolar complex reconstruction. Another advantage is flexibility. The EELD approach can be adapted to different mastectomy incision patterns. It can also be used for the salvage. For example, vascularized LD tissue can cover the implant, or tissue expander is selected cases of exposure or infection cases. Breast surgery itself is also becoming less invasive now, year by year. Endoscopic and robotic nipple sparing mastectomy can be now performed through increasing small access incision all over the world. So in patients with breast hyperplasia, this may mean that there is no incision scar on the visible on the chest or everywhere because they are congenital. How do you treat these kind of cases? If a breast surgeon performs a mastectomy through a roughly 40 millimeter axial incision, the reconstructive challenge for us is clear. Can we also transfer adequate tissue through that same skin incision, or only 40 millimeter skin incision? Can we elevate the latissimus dorsi? It's a very important question. Using a single port endoscopic platform, we demonstrated that the EELD flap can be elevated through a 40 millimeter skin incision with only 2 additional small 5 millimeter holes. Let's see the movie. After securing the thoracic and dorsal arteries and veins, insert a multi-port access device on the axilla, just under the axilla, and you can see the tape was the thoracic dorsal artery and vein. 23 gauge needle was used to where we are now. And the dissection was started from above the fascia, above the muscle, preserving the vascular pedicles. Dissection of the layer beneath the latissimus dorsi power moderator. We should dissect under the muscle and above the muscle. Dissection of the subcutaneous fat layer was it is important to include the adipose tissue to the flap. Dissection of the origin of the latissimus dorsi latissimus dorsi muscle. The muscle was completely released from the back area to transfer. Include as much as possible to increase the volume, maximize the volume of the flap. Okay. Even when there is no chest incision in the patient with congenital disease, the tissue can be transferred through the axial axis and small drain holes. This brings us closer to truly scar-minimized autologous breast reconstruction. We are approaching the scarless surgery little by little. In our 49 cases series, there was no conversion to open surgery and no severe perioperative complications. Donor-site infection occurred in one case, and one patient required nerve resection because of LD muscle twitching. On average, flap volume stabilized at about severity 70% of its initial size. Overall, the EELD flap can be adapted to the different mastectomy incision and can also be used for selected salvage cases and breast hyperplasia with an acceptable complication profile. What about the robotics? We have not started the robotic surgery because the government prohibits these cases using a robot. Conventional endoscopy has a limitation because rigid instrument cannot easily navigate around the curvature of the limb. A single port robotic system with articulated instruments may reduce the need for additional ports in future. We should try in future, but we cannot start just now using robot. However, both robotic and endoscopy LD techniques face another challenge: volume. Volume is not enough. A minimally invasive harvest is useful only if we can still obtain enough tissue for breast reconstruction. Our current answer is EELD flap combined with lipo filling. In our case series, this strategy enables scar-minimized auto reconstruction for breast below approximately 350 milliliters. Sometimes with one additional lipo filling session. Next, I would like to discuss keratoplasty with a short time. We have a little time more. Keratoplasty is a very important disease for Asian because Asian population, our scar is very visible compared with Caucasian. This makes keratoplasty biology an important area for international collaboration between Japan and Indonesia. Our recent study focused on piezo-2 protein, a mechanosensitive ion channel. We found increased piezo-2 expression in fibroblasts and endothelial cells populations within the keratoplasty tissue. I introduced this basal research with 5 minutes or less. There are many characteristic histological findings, including hyalinized collagens, increased fibroblasts and bases, nerve fibers, and inflammatory cells. However, conventional histological alone does not reliably distinguish regions with high and low recurrence risk. Mechanical stress is clearly involved in keratoplasty progression, but the molecular mechanisms connecting mechanical force to fibers has remained incompletely understood. This led us to investigate mechanosensitive molecules. Histological findings show piezo-2 positive cells in vascular and surrounding fibrous region of the keratoplasty dermis. Importantly, a region with higher piezo-2 expression showed a higher recurrence rate in our cohort. This suggests that piezo-2 may have value not only mechanically but also has a potential biomarker of the recurrencing keratoplasty. We then perform the single-cell RNA sequence to identify the cell population associated with PAZ2 expression. Compared with normal skin, carriers showed characteristics immune, vascular endothelials, lymphatic endothelials, and fibroblast populations. Within fibroblasts, single-cell analysis identified a specific subcluster characterized by PAZ2 expression. This suggests that carrier fibroblasts are not a uniform population. The proportion of this fibroblast to population was higher in carrier tissue than in normal skin. Fibroblast 2 also showed a higher expression of mesocollagen genes together with PAZ2. This links the PAZ2 positive fibroblast states with a strongly fibrotic phenotype. Cell charter analysis suggested that PAZ2 positive cells actively communicated with stromal and immune cell populations. Therefore, PAZ2 may be part of a broader cellular network rather than acting a fibroblast alone. To summarize this study shortly, PAZ2 was highly expressed in recurrent carriers, particularly in dermal fibroblasts, lymphatic endothelial cells, and vascular endothelial cells. This PAZ2 positive population also showed predicted cell-cell interaction with stromal cells, endothelial cells, Schwann cells, and immune cells. This provides a framework for understanding how mechanical signaling may influence the entire carotid microenvironment. Our next step of this basic research to evaluate PAZ2 expression as a biomarker of recurrence risk and explore therapies targeting this pathway, including immunotherapy. I'm also very interested in comparative analysis of carotid tissue from Japanese population and Indonesian populations, focusing on biological difference rather than simple ethnic labels. There might be some difference between the human populations. The latest chapter of today's talk is about collaboration between Japan and Indonesia in plastic surgery research. After hearing what I had to say today, did you find any similarities between what I shared and the issues and the differences you are facing? Across this project, our approach has been consistent, innovate in surgery, move repeatedly between the bedside and the bench to side, bench to bedside, bedside to bench, and collaborate closely with engineer researchers and basic scientists. At the same time, we are building larger clinical research institutions in Japan, include guidelines, nationwide epidemiological studies, and registry-based research. I'm in most of the field of lymphedema. I'm a principal investigator in Japan. Standardized data are essential if we want to move from individual experience toward precision surgery in future. The next step should be broader collaboration across Asia. As chair of the A+ Education Committee, I hope we can develop new projects with A+ member countries, especially you, and especially new project bridging Indonesia and Japan. Based on what I questioned to the ChatGPT last night, and based on what ChatGPT found for me. Of course, there are both similarities and differences between Japan and Indonesia. In particular, while Japan is an aging society, Indonesia is a very young and energetic country. After hearing what I had to say today, I discussed today. Did you find any similarities between what I shared and the issues you are facing? Here's what I have to say. Lymphedema, people in Indonesia focusing on prevention and early intervention, breast, endoscopic and robotics techniques being spreading in Indonesia. What are their current indications? What is problems in breast reconstruction in Indonesia? And keloids, how are the patients treated now? And their population-specific differences in their pathophysiology. Of course, as a kind of disease, welcome to discussion. In what other areas might we be able to pursue? I belong to university hospital, so lots of types of disease are treated in our department. Thank you very much for your attention today. It has been a great honor to speak with you today at Gadjah Mada University. Let's talk about future collaboration from now. Sincerely hope that today's discussion will lead us to new friendship, new research, and new collaboration between Indonesia and Japan. Thanks so much.
Thank you very much, Dr. Akita. Please join me to give a big applause for Dr. Akita. Dr. Akita, may I invite you to join me at the front?
Of course.
Yeah. Please have a seat. Yes.
Okay.
Here. Okay, thank you very much once again, Dr. Akita, for your fascinating and comprehensive presentation. So we have heard from the clinical perspective. Now we have another interesting lecture. So we'll hear from the biomedical engineer perspective. Yeah. So I believe also that we have many questions to Dr. Akita, but I think it's better to bring the questions after the second lectures from Dr. Ridwan. Okay. Yeah. Okay. Right. Okay. Yeah. So it's my pleasure then to introduce our next speaker, Dr. Ridwan Wicaksono from the Department of Electrical Engineering and Information Technology, Faculty of Engineering, Universitas Gadjah Mada. His work focuses on biomedical imaging, electrical impedance tomography, or EIT, medical instrumentation, artificial intelligence, and medical technology development. His lecture today is entitled Translational Innovation in Surgical Science, Integrating Biomedical Engineering with Lymphedema and Breast Reconstruction. Dr. Ridwan, please, the floor is yours.
Well, good morning everyone. Assalamualaikum warahmatullahi wabarakatuh. So it is a pleasure to be here. Thank you for having me to be invited in this event. And ohayou gozaimasu, Akita sensei, long time no see. And also for the faculty representative and also Dr. Sarjito Hospital representative, it is an honor to be with you now. And we talk about the current research about integrating biomedical engineering with lymphedema and breast reconstruction. So first, let me introduce myself. I'm from biomedical engineering, especially for under the Department of Electrical Information Engineering. And during 5 years, I did research about the imaging and also artificial intelligence, assistive technology, and also the smart intelligent instrumentation for medical device. And also I was graduated from Chiba University. I'm so proud that my device was there in your PPT. It's about EIT. And yeah, it's a long journey to make a medical device, including smart device for medical, especially for breast and lymphedema imaging. And also I would like to express my gratitude for my friends and my colleagues, Dr. Sun from China, Xi'an University, Dr. Kali from Vocational School of Universitas Gadjah Mada, and also my students, Alfian Dafa, Wita Radia, Cenania, Ali, Danis, and Yahya. And today outline, we will talk about sixth term. But I think all material already given by Dr. Akita, including EIT. So it's a complementary knowledge to deliver to you all. And yeah, let's start step by step from the clinical problem until the transnational and collaboration for the future project. So yeah, I believe all of you already know about this issue that Indonesia suffer for cancer by new cases since 2022, and it's going increase and increase. So that's why all medical doctor now put hard effort to develop the method and also develop the software or device to be used for human welfare, especially for the patient. Sorry. For the hospital clinical process. So, I think it's okay. Ya, makasih Pak. So, yeah, as a follow-up that Dr. Akita told us, we have a lot of problem from the beginning until the end. I mean, we have some point of view here, not only for the engineering side, not only clinical side, but also the society acceptable side. So, and also funding as well. So we have need to make a collaboration in serious period. I mean, it's not only 1 or 2 years, but it should be sustainable. And you can see that our challenges in Indonesia especially, more than 60% projected growth in Indonesia case burden from 2025, and it's predictable until 2040. So for current condition, that after axillary lymph node dissection, we have descendants of so many diseases. Yeah, that's why we want to talk about from the clinical process and then imaging process until the pathology, until the sequencing process. But maybe I'm not so familiar with clinical process because it's directly from the practical medical stuff. Maybe I will share my experience in electrical impedance tomography and also data analysis regarding how to develop deep learning for this lymphedema and also breast cancer issue. Yeah, as we can see from Dr. Akita's slide, that we have normal lymphatic drainage and also post-line obstruction. That some note in our in patient maybe dermis or muscle and fat layer also, the lymph vessel blocked because surgery or maybe trauma. So the body inside the patient becomes swelling, right? So when the capacity falls below lymph load, the protein-rich fluid accumulate in interstitium. So in this phenomena, in engineering point of view, we can convert biological phenomena into physical phenomena. That's why we can detect kind of area and also volume and also some imaging spot. It's not stop here because we have some challenges in engineering point of view. We have a lot of noise that not really used for the clinical process. So that's why how to remove this noise, how to extract the information, that's very important for medical doctor or medical staff. So yeah, this is just a resume from the forward model, how to modelize the biomedical phenomena into physical value and then make a reconstruction and do the segmentation and evaluation. Because we want to develop the system that can assist the doctor, so it should be validated by medical doctor itself. We cannot stand alone, right? So that's why in new department in our faculty, department of, not department, but program study of biomedical engineering, it's difficult if we stand alone to develop a device or develop a program that's not assisted by the medical doctor. So we need you actually. And also we can collaborate in the future. So yeah, this is the lymphedema case, for example, for the leg point of view. And then also we can see the conventional detection methods such as ultrasound, which is low resolution, and also the monitor can change not continuously, yeah, because we need time. And some part in Indonesia, doctor, we don't have enough devices to do the clinical process. So EIT offer non-invasive imaging and also early stage detection. And we need to improve the accuracy and sensitivity compared to ultrasonograph. So that's why one of study in our faculty now regarding the lymphedema, and we want to modelize with artificial intelligence, especially in reinforcement learning or RL, that has potential to provide real-time adaptive stress control and physiological response. So before we do the system in the patient, we need to simulate first firmly in the software, right? And before doing to the patient, we need to confirm to the maybe animal or phantom, because we have a lot of work in clinical ethical clearance. So that's why still challenge in our department. So if we can collaborate to do the ethical clearance, and also, yeah, we build the roadmap from the beginning into to the end, we can make it easier and also gather some maybe kind of stakeholders or funding. And yeah, this is the last 2 years I did with my student, the lymphedema case and also the sarcopenia, because both of them reflect the physical phenomena that the volume change on the human body. And we can compare the system based on the gold standard, which is MRI from lymphedema, and we can compare the accuracy as well. So yeah, this is the stage of lymphedema from the subclinical and then spontaneous reversible and also not spontaneous reversible until the severe condition, including how to put the sample from the biopsy, and then we put into a microscope and we make analysis of cell detection. So I will tell to the next slide. And for the ICG pattern, we can see the stages, the severity stages from the first early detection until the advanced lymphatic backward. So that's why the dermal breakthrough here, this is just illustration I generated by my best assistant 24 hours in the day, ChatGPT and Cloudy. But please, doctor, don't use the free version because sometimes it's misleading. Please put effort to pay to subscribe the Cloudy or ChatGPT. So it's more accurate actually. So that's why from this illustration it gets where to place lymphatic a sensor, for example the anastomosis, and also predicts what anastomosis can achieve. So sometimes I imagine that some medical doctor that without any engineering modality or device, maybe it's just like a prediction. So some malpractice and also not accurate decision happen there, and the patient become victims, right? So that's why we need to collaborate with the LNG engineering side to assist the doctor decision. And we have what kind of the topic is decision-making system, or DSS, I forget. It's a IT point of view that we collect the data, and from the data recording, we want to compile the best evaluation and best decision for the clinical process. And yeah, maybe I will skip this one. Yeah, the evidence from the PREVENT randomized trial. We can see maybe you already have or supervised by your senior or your professor that so many patients randomized to bioimpedance, and every single patient has different condition, right? Yeah, it's very complex. Not only fat layer, muscle, and also the cancer itself, but also the BMI as well, and then the environment condition, so many things, there's so many factors. So how we need to do? We should break it step by step. So break it down. Not all first-style condition could be included. So based on previous modality that Dr. Akita said, LVA and also VLNT, ILR, and DIPE, all of them already become like a gold standard for the clinical evaluation. But we still have a gap how to detect in real time and maybe remotely from the different position or different location, and also including the robotics as well. So some research in overseas, they already use robots, and the doctor in the different country, but the surgery in the different country as well. So yeah, this is the three gaps that engineer can actually close. Yeah, framing the research program, for example, the temporal gap, the spatial gap, and access gap. So for example, we need a measure, a device that repeatable weekly at home without any clinical visit, or ambulatory device that patient can use this device independently, or spatial gap. For example, to know the extracellular fluid distribution without visiting the hospital. So this is just like a preliminary clinical assessment, like if you have, how can I say, tensimeter, yeah, to check our condition in the first trial. So we need, and the patient no need to meet the medical doctor. And I often get like comments from pathology doctor that she said that if a medical device becomes smart, artificial intelligence implemented in the system, so what else the doctor can do for the patient treatment? Because all already handled by robotic system and artificial intelligence. And also one of the CEO of, I forgot the name, Elon Musk, he said that the first job that taken care by the artificial intelligence is radiology. So be aware, the young doctor, be aware for your future career. If you are not study about artificial intelligence, you will be replaced by this system. Okay, the next part about the engineering foundation. So for the electrical impedance tomography, basically consists of this concept of Kolkol locus or Kolkol plot based on impedance itself. So to model impedance from the human body into physical things, we use resistor and capacitor like this. So this is very, very simple model that we can do approach beside doing clinical trial. So by looking the pattern of bioimpedance spectroscopy, some researchers already resumed I think from 18th something, yeah. It's very, very complete data, and it's developed, update until now, 26. And we can modelize the system and predict the frequency response to the conductivity response. Yeah, for example, this is kind of cells. Yeah, if we inject the current in low frequency, the response of the how can I say, the current in depth in our human body, it's extracellular. But if we inject with the high frequency, the current pass through the membranes, and we can have different response. So, for example, this is just illustration how to inject the current in cellular form, and we have also the plain, or just like a plain current injection without a closed boundary. But in this slide is a closed boundary. So based on this 16 electrode and 50 kilohertz and some pairs of record, we can sweep and we can get data until 280 measurements. So the more sensor or electrode placed on the boundary, we can get more data as well. So this is the illustration how to build a reconstruction. Maybe in medical doctor equipment or in hospital, we just used and we become a technologist. But inside this device, we have a lot of math, physics, sometimes clinical process, chemical process, and how to reconstruct an image is very, very complicated. So I ever heard one message from Professor Yao from Jinan University. Some students said, for what we study about math and physics. He said, because that student didn't do high-level research. If we do high-level research, or maybe PhD student here, you can get a lot of novelty about this combination between clinical, biological, and also engineering point of view. This is just an example of my dissertation in Chiba University. Before I talk more about the lymphedema, I would like to give illustration how EIT works. We can see just directly to the corner of the right side, we have mechanical and chemical phenomena that change during the gastrointestinal processes. And also we have some disease like dyspepsia and functional dyspepsia. This is an overview, but I want to give this illustration that when we have physiological change, we can convert into electrical phenomena change as well. And this is the illustration, and sorry, this it doesn't work. But the right one, it's based on the ultrasonograph. And we also compare between modalities, for example, EGG, ECG, or maybe in lymphedema clinical assessment we use ultrasonograph and also ICG as well. And also the gamma radiated medical device, for example, SPACT, MRI. MRI is safe, but all of them has lag actually, and also EIT also has backward. So the future research we can combine between the high or expensive medical device with the low cost but real time and more accurate. For example, this is endoscopy. It's invasive, inconvenient for the patient, cannot visualize the shape and volume. It's just a prediction based on the two-dimensional. And also ultrasound here cannot measure directly the chemical assessment. For example, the pH. At the time, I used ultrasound for gastric assessment. And scintigraphy, we have known that this very invasive using gamma liquid, And also SBICT also, it's provide accurate 3D image, but cannot measure pH value as well. And the other development, we know already the capsule. Some of candidate of PhD in our department also proposed this, but for the clinical process it's very, very difficult. So that's why we provide this EIT, electrical impedance tomography, by using the impedance analyzer, and we create some PCB to make a sequencing process here to gather the data in close boundary. So we have hardware issue, software issue, clinical issue. So this is just illustration what Akita Sensei already displayed before. We have a real-time measurement, because when we move this object, the signal also changes. We can see there are two signals here. The yellow one is voltage, which is related to impedance change, but the pink one or magenta one, this is the current injection, should be constant during the measurement. That's also one topic, very, very difficult how to stabilize the current. That's why also one issue in medical device, how to get the ISO certification or IEC or the certification from FDA as well. So we need to divide by three, the hardware concept, software concept, and clinical diagnosis. Also in lymphedema and cancer, we need to divide by this at least 3 stages. This is I should identify the anatomy, the location, and also the effect or response beside the other organ or tissues. For example, I want to just extract the gastric phenomena, but it's influenced by liver, it's influenced by spinal cord, kidney, and so on. So that's why this electrical impedance tomography should be combined by the advanced kind of algorithm. And now we have the development of machine learning, not only machine learning, but until deep learning, and the new one is agentic AI. So I imagine for the future, maybe doctor just said to ELLM, for example, ChatGPT specifically for medical doctor. So just put the comment by voice recognition, and the system can scan and identify and provide recommendation directly. And also because my research previously in gastric, so I want to validate my system by using gastric juice, artificial gastric juice. So I made this by studying the component, the elements, the substance, and so on. And I include the mathematical formula and also physical and chemical also. We have electrochemistry here, and it's also very, very high impact journal if we want to study about this. And yeah, this is just my proposal in previous project. And this is the Camins, one of the machine learning implementation in our device, that we develop sectorial impedance for epigastric region. For the typical AIT, it's blurry and not accurate, but by using this algorithm, it's more accurate. And this is kind of clinical process of EIT, and we can see the change during the drinking stage, when the stomach is empty until full, and then this is full, and then we have retention level reconstruction. So by using this K-means or machine learning, we can project the pattern. Without this machine learning, the pattern is not in line with clinical process. But with machine learning, we can see the red line, it's going decrease following the retention level. Why it's not stable, directly like linear line? Yeah, because our gastric, we have gastric motility, right? So it's changed every minute. And also the advancement of EIT, not only for 2D or two-dimensional projection. Now we clearly can develop for the 3D assessment. So the image can be projected as 3-dimensional, and we can evaluate not only spatial evaluation, but also some voxel or pixel inside indicated as a tumor, or maybe several specific layers, kind of fat or muscle and bones. Yeah, this is actually Ryoma Ogawa's stomach. It's 2022, I think. And yeah, we include Jacobian metric as a mathematical concept in engineering point of view, and also we include some medical electrodes. It's a gel electrode here, and we modelize the stomach abdomen shape into a phantom like this one with chamber, and we compare the signal and we get the result. Yeah. So based on this result, actually not really similar with our stomach, but we have extract the phenomena. This is the phantom that I use in chamber, mimicking the abdomen of human. And when I implement to the subject, from the first subject until 16th subject with the same healthy subject as well, yeah, we can project different images. So by using qualitative, it's not enough. So that's why we want to extract more deep or deeper analysis, and also more complex graph in order to get the right decision. So yeah, for example, this one, let me zoom it. We have projection of the conductivity and pH, and we can clarify which the true healthy and unhealthy. And this is the ground truth to define this subject approach into the true healthy or unhealthy person. So based on this graph, we make a formula to have like a scoring system. So by using this scoring system, we can provide to the medical staff that this is firm, and we can evaluate without any ambiguity. So let's take a look at the lymphedema for our session today. Yeah, actually, to be honest, I resumed about 160 slides in one night to provide. It's very, very long talks actually, but I try my best. So the problem, nobody had solved this lymph problem. So we can see in the hospital, maybe the phenomena of lymphedema disease already identified when the patient come to the hospital or medical doctor. But before that, in early stages, yeah, some patient doesn't feel anything, like it's normal. so that's indicator that almost medical device cannot project the early stage, except if we have clinical surgery or maybe detection from the cell point of view, the phenomena inside patient's body. So that's why EIT want to provide mismatch of this concept, the geometry error and forward model and emerge display target. For example, one side to the other side is not balanced, yeah, the leg or maybe the arm, little bit not so swelling, but the patient feels it's different. Yeah. So the latest publication that I published maybe last month, yeah, I proposed DG unit architecture for the deep learning. The principle of circular detection to detect the swelling, yeah, to the leg of patient, and we get the data and combine it to the machine learning. So development of BC or boundary connected, Yeah, we use UNet as a deep learning method with the architectural change validated by systematic ablation. So, yeah, we have in EIT, we have some ground truth and algorithm how to project the object, and we should avoid the blurry images. Yeah, so classical code triangulation, this is kind of a method in imaging process. Yeah, we can use this, but still not so accurate. So that's why the boundary adaptive learn pipeline and also detect the count, what is the boundary, not only boundary, but also the shape, the irregular shape of the leg. So this is just illustrative of our project before, and you can see here we can evaluate the dice evaluation, area error, and normalize, which is the previous or typical deep learning cannot project so well. But in my system, yeah, we can project better and better. And we have two systems here. The first, the system should detect the boundary of outer layer of skin. The second one, the system should be predict the inner layer boundary. Yeah, that's very, very challenging. But yeah, alhamdulillah, we can publish in the Q1 journal. You can check by yourself actually. So by ablation study finding the boundary guidance branch, this is just maybe very, very small part topic of lymphedema, but actually I think medical doctor need this boundary evaluation. So by using manual, maybe yeah, doctor can using by measure, manually using what is measure, right? But for the data recording, it's too, I think, not so efficient if the medical doctor put the data one by one to the computer. If the patient increase and increase, if the patient only 1 until 10 per day, it's okay. But if 100 or 1,000 patient and we need to record in the same time, yeah, it's not so efficient. So that's why the surgeon will actually do with this is screening and planning, monitoring and staging. Yeah. It's same with the previous modality that Akita Sensei told before, LVA, VLNT, and the other modality like ultrasonograph. Yeah, but this EIT actually provide alternative for the simple and how can I say the low-cost measurement system. But it's not comparable with the MRI actually. Yeah, this is just illustration how to detect the boundary. We still have a lot of backward this EIT system, so that's why the combination between EIT should be provided in the future research. Yeah. Sorry if some of my slides still Indonesian because I got it from my student. But yeah, basically it's same system with the Take Sensei's system in Chiba University. And maybe this is not so familiar for medical doctor. This is to engineering. Yeah, for this one, that's a clinical physiological response with, under the EMS, electrical muscle stimulation. So one therapy that lymphedema patient recommended by the medical doctor is using a massager. Yeah, so we can replace the massager by using electrical muscle stimulation. Yeah, and we have evaluated this by the scheme like relaxation, massage, and then put the cold pack, hot pack, and we want to know that is it EIT possible to project the different phenomena here or not? So the evaluation focusing on the area of the muscle. Yeah. So we need to distinguish some compartment muscle in human leg. For example, M1, M2. This is M1, M2, and the other muscle compartment. So yeah, this is the discussion about the future research, I guess. Yeah, because we want to combine between physical phenomena, physiological, and also pathology. I guess some phenomena, pathological phenomena change can relate by the boundary physiological change, and we can explore more about the, for example, the fibula here, that's growing or depressed. So that's why, for example, this ultrasound liner probe, can be combined with EIT to detect the blood flow velocity. And also, in order to create more advanced imaging, this USG or ultrasonograph, which project two-dimensional image, we can arrange the position and we can develop algorithm to make three-dimensional point of view. This is a kind of a new approach for ultrasonograph implementation. This is just an experimental protocol that we use in our lab. Actually, the same device that Akita Sensei displayed before. And we have evaluation like this. For example, we have level of EMS 1, 2, 4, 6, 8, 10, 12, and so on. So the phenomena change can be projected by EIT. So that's why for the qualitative reason, increased conductivity, including conductivity change during the stage of lymphedema, can be projected well. And this is also the thickness can be evaluated by the ultrasonograph. Like this one. We can measure the depth by different subject, and it's still not enough. Some messenger, not only EMS, the messenger of message machine developed to reduce the effect of lymphedema. For example, this one. I think some marketplace already sold this kind of device, how to compress and relax the muscle to, like a messenger. And then we develop using the compression, using the RL or reinforcement learning, the machine learning system, based the pressure, we can see there some compression mode. We have gradient, intermittent, and mode compressed peristaltic. And we want to evaluate the effect, the control system first, and then the effect after compression. So that's why we need expert-edge, cutting-edge portable device like NVIDIA Jetson Orin Nano, in order to easy to move different location and easy to use by the medical staff. As an illustration that our control system is inside the environment, and the learning system, we call it agent. The agent actually evaluated by reinforcement. If the system do well, a good response, so we give the reward. If the system cannot provide not a good therapy or treatment, we can get the penalty. So that's the idea of learning algorithm in reinforcement learning. So based on this parameter, it can be thrown to the environment, to the control system, and we can control the proportional, integration, and derivative controller here. And the pump, which give the pressure, can press as expected as patient want. For example, this one. This is the device, and I would like to show this graph. The convenient pressure from the patient is the after 300 step here. But before get the expected value, the reinforcement learning give the reward and punishment like +1, -1, +0.5, -0.5. It's included in based on the human perception. So we combine system not only the device only, but also. Thank you. How to? Okay, not only the device only, but it's include human. So we call it reinforcement learning and human response. Yeah. For example, this is the algorithm how to put the reward and punishment, and this is the pressure response until the system can provide the best expected value. Yeah. So regarding to the lymphedema and skin, we also have research about the skin optical point of view evaluation, which detects the bilirubin. Yeah, the bilirubin which sometimes happen in baby, the bayi kuning, green baby. So we detect the bilirubin potential before get suffer, and how to respond if this potential happen. So by using optical sensor, we develop like this one for the bilirubin monitoring, and actually it's helped medical doctor to define the phenomena on the skin color. And regarding to the breast, I will tell the next slide. Just this is the preview of our capstone project, that we want to put a electrode sensor here, and also the treatment. For example, if you ever heard about the fast that can treat the breast cancer, it's from Pak Warsito, if you remember, how to treat the breast cancer not going increase bigger, or even want to decrease the effect of breast cancer. So we want to combine that, and then we use EIT system and also IoT and also artificial intelligence. So this is just an effort that we want to make a different point of view, different way how to treat the breast tumor. We using the multi-wavelength diffuse reflectance, and by this reflectance area inside epidermis or dermis, we can get the response, and then we define the phenomena inside the skin. So the challenge is the sensor itself, the model, and validation. So in terms of medical stuff, maybe validation is very challenging as well. How to treat patient, to evaluate this model is correct or not. But in engineering point of view, this model evaluated by dataset. For example, we have open dataset from some resources. It's subscribed or the free, but the result is good. So maybe this is, I will skip, just like a surgical lecture for flap perfusion, skin assessment, and platform economics. This is the core of my presentation about imaging of breast. So as illustration, here we have dielectric contrast, and every single human, maybe, I believe it's different. The breast shape, the fat inside the breast also different, the volume also, and if there is a tumor here, location cannot simply identified until this tumor getting bigger and bigger. So malignant tissues show elevated permittivity and conductivity. This is the key of physical phenomena that we can project to detected by sensor or imaged by the system. So current status, that phantom vector network analyzer in place with antenna. We have two modality in our lab, we develop electrical impedance tomography and also microwave imaging. Later, I will compare the performance between modality. So, okay, this is just like a spider graph about EIT, optical and microwave imaging. For example, this portability, yeah, 3 of them, it's good. But for the spatial resolution and depth presentation, it's different each other. So that's why EIT offer depth and functional contrast, but the millimeter depth, it's not good and not better than microwave. So yeah, this is just comparison, and we can see here that the latest research about analysis depth learning reconstruction for post-processing cannot be acquired by device itself. So we need to combine with the deep learning algorithm, and we analyze multi-slice images on the breast. Yeah, and we compare between modalities like mammography and then MRI, ultrasonograph, and we want to project this limitation because our orientation, like proposal of Taki Sensei in Indonesia point of view, he want to acquire the population in rural area that has a limitation of medical device, and yeah, this kind of modality is very expensive and some of them not portable well. So that's why EIT proposed to cover that limitation. So this is form of signal in EIT. And last capstone project, we have a good images of comparison between left and right breast condition. If the boundary change or maybe some tumor malignant happen there, so it can be projected well. And also we have some engineering problem like ill-posed problem and then non-unique solution, noise as well. Yeah, so that's why it's still explored by my student until now for my master and my PhD student. But yeah, it's very, very engineering, so I will skip this. Yeah, maybe this one. This is a breast phantom that we developed with a vocational school, Universitas Gadjah Mada. And we want to put this sensor layer by layer. This is 3 layers. And I think Akita Sensei already know this presentation from Galih Sang, yeah, one of PhD student 2023. And we want to project in slice by slice, the different phenomena and the spreadness of the cancer. But it's difficult, yeah, it's very difficult. And yeah, this is just the illustration. Yeah, for example, this, we have different size, shape, and texture of breast, like Akita Sensei's presentation before. And we need to define what's our expectation using this device. Yeah, sometimes we have a sophisticated device, but we don't know how to use it, or we don't know the purpose of the performance of this device. So yeah, we want to know the invasive ductal carcinoma here, and we have several images and confidential. So please respect our work. I really know Akita Sensei why he requests not to copy or take a photo of our presentation, because yeah, this is not only patent or company point of view, but also the ethic for the patient. Yeah, I will skip this, and this is our works to measure the impedance directly to the specimens, to the breast tissues. And some of tissues contains carcinoma, and this we have some identified location. And still the challenge how to make sure the position of electrode that can define specific area that contain malignant tissues. Yeah. For example, this is normal granular, this is adipose, yeah, this is IDC. And yeah, we need to combine with a pathological assessment point of view to evaluate our result in practical or clinical assessment. Is it correct or not? So based on this goal, to conduct analysis of frequency optimal, to perform detailed comparison effectiveness between imaging reconstruction. Yeah, we want to modelize into physical parameter. Yeah, and then we input to the algorithm. We simulate by, we call it COMSOL. Yeah, we can. It's a multi-physics software. Yeah, we can use the COMSOL before we do from the living things like animal or human. Yeah, this is layer 1, 2, 3, 4. Yeah, and we can specify on the different conductivity happens in layer 1. Layer 2 is not so bright. 3 and 4 are still good. So based on this illustration, we can specify on the tumor is deep inside in the layer 1 here. Yeah. And yeah, this is one of advancement of EIT that we can provide a real-time monitoring without any surgery in the first stage. Yeah, this is the illustration and the reconstruction here, the layer 1, layer 2, layer 3, layer 4, and we evaluate the impedance pattern here. And this is the placement of breast specimen, not only directly measured in the human body, but we put the specimen inside the tank or chamber which contains the electrode here. Yeah. So to detect the IDC, we can see that in the clinical process, the breast will be placed on the holder, yeah, with this sensor shape, and then we can predict with the position and also the area. Yeah, yeah. This is the image from, I think, from MRI, CT scan, or yeah, I think CT scan, and we can see here the IDC here, and we make a simulation first. The simulation following the real patient condition. So we don't make simulation just blank imagination. Yeah, we should reflect on the patient condition directly. Yeah, this is the result. And yeah, I think based on this quadrant, 1, 2, 3, 4, yeah, just roughly, our patient can detect the position of cancer and treat this cancer well before going to the medical doctor. And the last one, how to confirm this tumor development, not development, or yeah, how can I say, the tumor perkembangan, development? Not really development, yeah, it's the staging, yeah, the staging. So we need to do biopsy, and this, I put a melanoma case, not breast cancer, because our collaborator from pathologic anatomy, we have several cases, and we have staining process there, and we want to detect directly to the CD8 plus. Cytotoxic T cell, yeah, which indicate the cancer cells. And based on this pathologic process, sorry, still Indonesia. Yeah, actually, manually, the pathologic doctor identify and annotate, oh, this is cancer, this is not. So it's very not effective at the process for the staining process, and then scan slide, and then annotate one by one. So we want to make automatic annotation for the standing imaging based on the microscope. And if we implement this algorithm into the portable device, it will be a lightweight algorithm. You know, like machine learning or deep learning, it requires very, very high computation. So that's why some engineering product needs a personal computer or GPU. That's not so handy. So if we want to make portable device for the patient, we should make it lightweight, but still accurate. Yeah, that's the challenge. So that's why this is from my student explore from the Puma dataset and how to extract CD8 or T cells. And we want to explore the lymphocyte here. Yeah. And the generation of lymphocyte will be projected to the whole slide image on microscope. So the first we need to filtering, like screening, this is pass or not, in order to balance the data set before we assess to the direct pathologic whole slide image. Yeah, by using processing and some algorithm evaluation, for example, normalization and then large nucleus selection and then boundary probability, it's very, very mathematics. But the substance, yeah, we have to do post-processing pipeline in order to project the segmentation stage. Yeah, for example, this is the input patching. And then we define the nuclei, we need to mapping and then have a boundary identification, and then we annotating by specific color. So based on this pathologic image, we have maybe more than 38 colors. Yeah, it's very complicated. But yeah, we can keep asking, which is the dangerous cells here? By using HNA tile and then IHC tile, mask tile, yeah, we need to segment the cell that we want to extract, and we can count, we can see the spreadness, the area, and it's still good or already metastasis. Yeah. So based on this train model, we can get the visualization like this. This is the first, the second, third. Yeah. Actually, one study of this matter is image processing. Yeah. In computer, maybe in medical device, you just click on the menu and click the feature like that. It's very simple for the implementation. But inside, how to define this color, it's very complicated. And some problem appear that how to define the boundary of cells. Yeah. You can imagine before we talk about the lymphedema boundary detection, it's not micro, it's maybe in millimeter or centimeter, but here it's the level is in micrometer. And also, how if the cells overlap each other? Yeah. It's also challenging for our study. Yeah, that's why we need to clarify it between dataset. This is PANUC and also Puma, Panoptiles, and then MANUSCAC. And yeah, before we implement in the direct pathological result. Yeah, now we proposed just last month, finished and accepted, published. Not published, submitted to the journal that we want to detect the boundary based on the polar point of view. Polar, we have, this is modulus here, and then we have theta, and we can project the boundary following the irregular shape. Yeah, the typical one, or maybe if you're familiar with YOLO system, yeah, Normally, system using only bounding box like this. Yeah, the bounding box cannot cover the problem overlap like this. Yeah, so based on this shape identification, the name of algorithm is ray casting. Yeah, the ray casting compute the centroid first and then project the line of the, what can I say, the modulus for the point. It's depend on the point. If the point getting higher, so it's more detailed and more smooth. And yeah, for example, this is the simulation based on the software we developed before. We have ground truth here. The prediction and the assigned and not assigned to GT, it's changed over time. So evaluation is used to evaluate or to iterate in the previous step, like this one, the architecture from the backbone, neck, and head. And we want to know the density of the cells. Yeah. And based on this raycast, yeah, we have validation. It's good and going well. And we can see some nuclei here, yeah, that in different shape, different irregular shape, we can project well, and it's become our new novelty. Okay, the last one, I think it's already 1 hour. Yeah. Yeah, this is PPT number 146. Yeah. So almost over. So the value of that is institutional, not technical. Some of challenges is in our country, for example, in Indonesia, how to connect between university and industry and also hospital. For university and hospital, maybe it's not so difficult, but to connect in the industrial point of view and the association, how to certify the device, it's still challenging. So, for example, this prototype and safety, some medical staff or maybe the stakeholders on hospital just import from the China or from the other technology. It's cheaper. Or maybe some of stakeholder already play a game there. So to develop the device, we don't have any room how to validate this prototype. So that's still challenging for me in engineering. So what working collaboration looks like? Yeah, we have engineering in faculty in Universitas Gadjah Mada. We have medicine faculty as well. And we have Chiba University that our bond is very strong, yeah, with some researcher there. For example, Akita Sensei, Take Sensei, we have Suji Sensei, and we have, I forget the name, Sugawara Sensei as well, yeah. And yeah, we want to keep contact them to evaluate and develop our system. Of course, if we have chance to do like a publication together or make an international patent as well. And this is open problem for our future project. For example, clinical validation, electrode interface, generalization, regulation, until sustainability. So we cannot, yeah, me especially, I cannot do without medical staff. So yeah, we need to contact each other after this session over. And yeah, this is the measurement gap between pathway. For example, from clinical point of view, we want to explore about pre-operative, intra-operative, and post-operative. So we want to know the trends, also what missing there. For example, spatial baseline sensor, the sterile low latency feedback, wearable home monitoring. Yeah. So yeah, this is from diagnosis, surgery, until survivorship. Yeah. The clinical monitoring gap still, yeah, we have a lot of opportunities to develop this technology or maybe new knowledge for clinical point of view. Yeah, this is the comparison that we can combine between modality. For example, this is low cost, the most cheap system, BIS, bioimpedance system, or bioimpedance spectroscopy. And then this is EIT because it uses more electrodes. It's complex using algorithm to define the image reconstruction. And also the microwave, which is used high frequency until order, I think, about 8 giga until 10 gigahertz. Yeah. And the future case study that I want to propose is EIT GRTD for breast tissue fingerprint. Yeah. Yeah, we want to know the relaxation time and distribution turns impedance into tissue fingerprint. And yeah, because it needs maintenance, not only one day. So I think we need to have a structural and firm scenario. Yeah, from the beginning surgery until the home maintenance. So wearable monitoring, periodic upload, and clinical threshold alert it's important for both sides, for example, patient and also medical staff. Yeah, this is we want to propose for the wearable sensor, and also the deep learning system, and we can develop until the multi-agentic learning system or multi-agent artificial intelligence. And yeah, the first or prior goals maybe just want to know the phenomena of spatial fluid map. So yeah, for example, we have known the ultrasonograph can detect the phenomena real time. Yeah, but real time when it used not wearable, but still we can see if the ultrasound attached to the skin, we can monitoring. But after that, it's lost. So that's why the spatial fluid map should be monitored in wearable devices. Yeah, this is the combination between impedance, ICG, and ultrasound. And we can state the estimation more firm, more trustworthy for the patient point of view. Yeah, this is the electrode and home monitoring clinical analysis. So in Indonesia, we have like a step how to form this product, call it TRL. Yeah, the higher TRL, the more from this project. So for the GSPS bilateral joint research with Take Sensei, we will propose this home monitoring called analytic system. And yeah, this is just a brief for the Japan side and Indonesian side that we already discussed with Chiba University, image reconstruction and prototype fabrication from Takei Sensei. And for my side, it's ethical proof, clinical evaluation, elicitation and surgical terms, and also the data acquisition for the rural area. So if you do a community service, KKN, yeah, maybe we can include this program into KKN also. So medical doctor that do the community service, just make a screening by a low-cost device. So you don't need to bring CT scan to your location. Yeah, this is the resume of our talk today about lymphedema overview, surgical treatment. Until this, we have electrical impedance tomography principle. So yeah, this is very long journey. We have some, not only one or two friends. I think 1,000 friends is not enough. It is for the human welfare, for the technology improvement. So we have a good intention how to help humanity, how to help people, each other. And this is the research kind of documentation of our department. Yeah, for example, this is enhanced unit architecture with CNN backbone for early skin cancer diagnosis. And this is the last one, our roadmap. We have collaborator for SysMac Japan. We have Asahi Kasei before, yeah. But it's 2022, after COVID, I remember. And we have costume, we want to develop this costume, how to monitor and wearable system. And this is lymphedema for the leg system. And later we want to implement to hemodialysis for the patient who has CKD, chronic kidney disease. Okay, that's all. Thank you so much for your attention. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Please give a big applause for Dr. Ridwan. Thank you very much, Dr. Ridwan. Yeah, please be seated at the front with us. Yeah, I have to admit also that I learned a lot, and there were a lot of new things, and somewhere between EIT, biomedical engineering, yeah, I realized once again why I became a surgeon, not an engineer. Okay, so yeah, now we have the discussion sessions, the questions and answers session. We have heard from the clinical perspective, and now we also have heard from the biomedical perspective. So, any questions for both of our speakers? Yes, please.
Thank you, Akita Sensei and Mr. Ridwan. I am Rianto, I'm a microsurgeon. Thank you for your great presentation, both of you. And for Akita Sensei, I'm interested in the potential clinical application of NCS, nanofibrillar collagen scaffold, according to Indonesian typical patient and Indonesian geographic as well. Typical of Indonesian patient that many patients reject undergo the invasive surgery. So, and also access to lymphatic microsurgery can be challenging because of our geographical distribution across thousands of islands in Indonesia. Based on your finding, which type or stage of lymphedema do you think would be benefit most from NCS implantations? And do you see NCS eventually being used as a standard alone treatment or mainly in combination with LVE or VLNT? Thank you, Dr. Akita. And also for Mr. Ridwan, I have some experience about developing bioengineering when I was in NTUH in Taiwan in 2023. There are some engineers that develop application in iPhone using their ability with, I don't know, they call it radar. So they develop application for measuring the volume of the breast, for measuring how big the tissue we harvest from the app for breast reconstruction after mastectomy. And I believe it's difficult because by now I check the application still doesn't work very well. Same the Dr. So we become the doctor actually. According to your presentation pre-clinic, what is the big boundaries to bring your idea to clinic or the patient except ethical clearance? And I have some interest also in temporary implantation device for evaluating the flow of vascular after microvascular anastomosis, because it will be big impact for me as a microsurgeon, and maybe we can collaborate it later soon as possible. Thank you.
Yeah, thank you very much, Dr. Rianto. So Dr. Rianto is our microsurgeon, also the chairman of this event. Yeah. So please, Dr. Akita.
Thank you for your question. Actually, in Stanford, the clinical evaluation of the nanofibrillar collagen has only performed by Stanford team. Stanford team has indicated this device simultaneously with flaps or simultaneously with LVS, because I guess the result of the nanofibral collagen alone is not very powerful, I guess. Actually, in Japan, we have never used for the patient this collagen nanofiber, and we have only the results of the basal animal experiments, and in our research, the immediate implantation is very greater result than delayed implantation. So in future, we are planning to, at the time of axial lymph node dissection, we should put the nanofibral collagen and without any flaps. Only putting the implantation. That method is very easy to perform the not super microsurgeon, even by the breast surgeon. So nanofibral collagen will be used for prevention of the lymphedema, I guess. In contrast, LVA is a very technically difficult. So now we are not planning immediate LVA at the time of breast surgery, actually lymph node surgery. We are indicating LVA as early as possible. They become lymphedema. When we can detect the symptom of subclinical lymphedema, we can indicate LVA as early as possible. But actually, lots of patients come to our department. They become very severe lymphedema. But now we are trying to LVA fast because it's very less invasive compared with VLNT. VLNT is used for the patient with very severely destroyed lymphatic function after cancer surgery or primary cases. In some of primary lymphedema cases, they didn't have any good lymphatics to be anastomosed. So in this kind of cases, we use VLNT. But the result of the LVA has become developing better and better by year by year. So the indication for VLNT has become narrowed recently. In our institution, more than 90% of the patients were treated by LVA. The indication of VLNT is very narrowed, very severe cases and congenital cases. Thank you.
Yeah, regarding the iPhone to detect or imaging the breast, it's not radar, I think, it's a LiDAR. Yeah, how to combine with camera with the LiDAR, the depth camera, so we can measure the depth, so we can project the three-dimensional images. And I think it's only in the surface, not till the inside the breast, right? Yeah. And also, I also interested with triangle structure of the nipple and maybe on the neck, that is external here. And we can actually some algorithm using the Python analysis, we can identify the normal or abnormal, at least normal and abnormal condition of the patient. And regarding the challenge of in our department and our research, because biomedical engineering is still new, I always talk with my student to go outside, have a job overseas, or take a master degree for the continuous study, overseas, not in Indonesia, because mostly in our country, the company or industry of biomedical device only relate on the cellulose engineering, so not deep inside the engineering itself. So some companies, literally just sells. So that's why our engineer, that a talented engineer, it's so pathetic if they just doing management sales and so on. But it's important as well. But if they want to implement the knowledge of engineering side, they should go outside to the company that build the product directly or develop the engineering point of view. And beside the ethical and the clinical and the statement, we have lack of facility, of course. For example, when I was graduated from Chiba University and back to UGM, my research was stuck about 1 year. About 1 year. And then, because some administration and some level of position, I didn't have any flexibility to do research and also purchase the facility. But now, get higher level, and I can collaborate with my ex-professor, my collaborator from China, from Australia, from Japan as well. So that facility can be accessed by that relation. So we don't have any facility here, but we can go outside. I think same with my friends in pharmacy and in this medical faculty as well. They need to do international collaboration because here we don't have any facility. And also one topic that's very interesting for the students for the future education, I ever had a chance to attend a seminar from, I forgot the professor from Europe in Proflina supervision, Proflina radiology, radiology. The professor said about the micro classification topics. So the modality based on the MRI and CT scan, but it can be explored until the micro classification level. So very, very, very small. So before surgery, the micro classification can be detected, and we can avoid the high risk surgery. Because if the cell is still very, very small and we can remove it, it can avoid the high risk condition. Micro classification. I think that's the modality classification. I think that's all.
Thank you very much, Dr. Akita and Dr. Ridwan. Any more follow-up question, Dr. Rianto? Okay. It has shown to us that modern reconstructive surgery brings together surgery, biomedical engineering. So it's now very advanced and very developed. Is there any more questions from the floor? We also receive questions from Slido. So here we have a couple questions. Okay, from Anonymous. Okay, for the first question, in late stage lymphedema, how do you decide between LVA, VLNT, and suction assisted lipectomy or combination? Maybe it's a clinical question from your clinical experience.
Thank you for question. Very fibrotic tissue cannot be resolved by reconstructive procedure now, so the preoperative imaging is very important. Very advanced fibrosis and without lymphatic function area was detected using CT and spectroscopy and lymphoscintigraphy. We should remove that area, and after removal, and we can develop the lymphoangiogenesis by compression and reconstructive surgery. We can recover the lymphatic function of the living area without fibrosis. So we should intraoperative CT imaging and SPECT CT imaging detect the areas which should be removed and decide the combinations.
Okay, thank you, Dr. Akita. And we have the second question. I think it's related to Dr. Ridwan. Can EIT device identify the lymph with good flow or poor one?
Yeah, actually, EIT device still has low resolution, so it's not good for limb detection, but for limb flow. But for the limb swelling condition, it's already implemented. And we have development of IC design that we can use as a wearable sensor, very, very small. And yeah, the size, about micrometers. From that development, we can put the electrode in several areas that detected as lymphedema. So based on the combination between IC design development, that it's use the flexible sensor and also using the micro electrodes, it's possible to cover the limitation of EIT, but it's still a long way. Yeah, maybe I'll also want to answer the fourth. Yeah, the drawback about the EIT tomography.
On the probe position.
Independent on probe position. Yeah. Yeah, as I mentioned before that we cannot specify the position directly by human eye because the tumor is inside fibroglandular deep inside the breast or the fat tissue. That's why we developed the three-dimensional imaging, not only two-dimensional imaging. And is it affect the result? Not so significant. That's why we want to combine by multimodality. So not only EIT itself, but we should combine by USG or maybe the mammography or ICG. Yeah.
Okay, thank you, Dr. Ridwan. And we have the third question. So I think it belongs to Dr. Akita. How do we decide that which patient may benefit from LVA and VLNT after breast reconstruction, breast removal surgery?
Yeah.
And do you also perform prophylactic LVA?
In Japan, prophylactic LVA is not covered by insurance, and some institutions performing immediate LVA. But in my own opinion, early LVA at early stage for breast reconstruction is very nice, and because our good results, the immediate reconstruction is a little bit time consuming, and we don't indicate it now. But in future, evidence is now accompanying from all over the world. So after it was proved to be better than early LVA, we will indicate them. I think.
Okay, thank you, Dr. Akita. Any more questions from the floor? Yes, please, yeah. Please introduce yourself and your status in your institution.
Yes, thank you so much. I'm Ahmad Fatan from surgery resident. The question for the Dr. Ridwan. What is the biggest challenge in integrating engineering solution into routine lymphedema care or examination breast care? Thank you.
Yeah, on the last slide, I showed about the safety and certification. Because we cannot do clinical process directly before we have certification and we have safety guarantee from the association. That's problematic for our experiment. And also, before doing that, actually our research team just sneaking doing a clinical trial to his friend or her friends in a lab, cannot doing directly to the patient. Yeah. For the multimodality, we can re-engineer. For example, we have new device and then we break and then we re-engineer, combine with our system, and then implement the deep learning. But still, after the complete product already generated, we cannot doing directly to the patient. So we need to do a lot of process, how to certify this, and then, for example, first patent, and then after patent, 1 or 2 years, and then get certification, and then not directly to the human, we should test in the animal first. Yeah, for example, the mice and also cow, pig, yeah. And after get the good validation, and then we get certification again and can go to the hospital. But yeah, just I mentioned before that our team is just sneaking how to implement in the patient. For example, when the community service of FK-KMK in Cangkringan, in Puskesmas, this device from Japan and has certification. So we took the data from this device directly to the Puskesmas, what is Puskesmas? The Central Health of Society, primary health care in Cangkringan. And we use that data for the develop our algorithm. So in that case, our research not on hardware, but develop the software. We use the eligible or the certificate hardware to acquire data, but the software, the website, the algorithm, the deep learning, it's in different work. Yeah, maybe that's all.
Is there any more questions? Or perhaps from the Zoom? Is there any more questions from the participants who are joining us through Zoom online? Yeah, while waiting, I would like to ask also to Dr. Ridwan. Engineers sometimes develop very sophisticated and complex technology, while us as surgeons sometimes simply ask, what can I actually use this in the operating room? So what do you think, how do you make sure that engineers and surgeons are speaking the same language?
Okay. I think we should have a same floor to discuss about this, because last time Sarjito has Da Vinci, the robot surgery, but the staff told me that Sarjito didn't buy it, just rent, kind of rent scheme, and now the robot just not in Indonesia anymore. So how to know the knowledge about the modern medical device during operation? It's we need. It's I think not only in our side only, not only medical or doctor or engineering staff, but also on the stakeholders, the facility as well, and how to make a same languages to how to operate, know the function, and also I think understand what doctor needs during operation, right? Yeah. So basically, in our capstone project, we have kind of open-ended solution, and we do a lot of interview and kind of assessment before we make a product. So yeah, some product maybe not so sophisticated. For example, one product, how to measure the what is the pressure of leg. Yeah, I want to tell about some research in sport science. Yeah, I ever asked to make a product to measure leg pressure for the football player, and it's very, very expensive. But if we know the technology, it's very cheap. so that's why we have gap also when we purchase a device in company or maybe certified device. It's very, very expensive, Even though we know the component, the system is not so expensive. Yeah. So that's the first step that we want to explore first before make product or develop product. We know the need of the doctor during operation. Yeah, for example, the lamp for surgery. It's not a single lamp like this. The lamp should be avoid the shadow. Yeah. So in every maybe hands of doctors in several location cover the object, the light still there. Yeah. So the reflection should be re-engineered. So that's why the need of doctors should be identified and listed in detail, like that.
Thank you very much. Yeah, I think we need more forum like this. Yeah. Okay. Any more questions? Yes, please, Dr. Lily. So she's one of our plastic surgery resident. Yeah.
My name is Ridwan, I'm a plastic surgery resident. I want to ask for Fatima and also Dr. Ridwan. The first one is that what stage this current technology ATA, if I'm not mistaken, for? Is it already in the critical stages? And then the second one to Prof. Akita, how far this technology can assist us in terms of deciding what kind of management that we are going to do after we got the data. And then the third one, I'm interested in the potency of this technology. If this technology is new, and then there must be a patent in this technology. Is it already going into there, and how what kind of patent? Thank you.
Actually, we have just now get the money from the government to investigate for the patients. Thus, our clinical prospective research will start in this winter because we have just get the money and we should plan for 34 months. So after that, our perspective, we should probe the diagnosis by EIT should be less correspondence with according with same results with ICG or lymphoscintigraphy. Because EIT is a non-invasive method, if the diagnosis is correct, the correction of the accurate of the diagnosis was proved, we can change the diagnosis from ICG or lymphoscintigraphy to EIT. After that, we should EIT to sell for the patients, and the patients can check their status of EIT in their each house. And if the result changed, they can go hospital and we can check using another devices. Then we can patients don't have to come to the hospital before the result was changed. After in this method, we can change the we can detect the lymphedema as early as possible. This is my future perspective using EIT.
Yeah, thank you, Dr. Lily. Actually, you are my junior in Delaware, right? Okay, so the current technology of EIT, for example, the commercial one from the Denmark or Europe product, we have a dragger for the lung monitoring system. Why it's very it's guaranteed and also valid measurement system for the clinical process, because the lung imaging project very different conductivity. For example, we have a lot of tissue in our thorax, but we just compare this conductivity of thorax with the air conductivity, which is the air conductivity almost zero. So the difference is very, very significant. And the projection, we can measure the lung volume, the breath rate, and yeah, some feature there. But yeah, now maybe after 2010, they explore about AI, and now until the step of agentic AI. Yeah, but EIT already commercialized, so you can search Dragon, and some Chinese product already developed. Yeah. But why Indonesia cannot gather? We have the same lab in PhD level, the same knowledge, the same facility, but after going back to our country, we cannot compete the Chinese product. Yeah. Thank you.
Thank you, Dr. Ridwan. Yeah, I think it's also because of the environment, yeah, the research environment. Yeah, maybe I can use also this opportunity to ask something more practical about future collaboration. So, Dr. Akita, from our side, we see several areas that could be potentially developed together with Chiba. Like, for example, you explained your lecture about breast reconstruction. We are very interested in minimal breast reconstruction, scarless breast reconstruction, because here in Sarjito we also have utilized the endoscopy and laparoscopy equipment. Do you think there could be an opportunity for a fellowship or clinical attachment in Chiba in this area?
Before that, do you use endoscopic surgery? In Indonesia, some plastic surgeons use endoscopy in surgery.
Yeah, actually, last year, yeah, we invited another visiting professor. So he performed the endoscopic surgery for harvesting the superficial temporal fascia.
Really?
The ST.
It's very nice. I have used endoscopy in plastic surgery for years, but actually the insurance cover of endoscopically assisted LD flap is covered from this June in Japan. So no other plastic surgeon has been familiar with endoscopic LD flap in Japan, also in Japan. So we have not decided the indications for the endoscopic harvest of LD flap because the elevated size is smaller than conventional methods. So we are performing a prospective study to determine the indication, and we are planning to educational system using cadaver in our university. In our university, we can use fresh cadaver for surgical training. So in future, this educational program will be open to foreigner, but just now only for Japanese. But we are just started. We have just started. In future, please come our university to train the endoscopic surgery from foreign country, including you, please.
Yes, thank you, Dr. Akita. So it's quite new, yeah. And then how about lymphedema and supermicrosurgery? Because we also have just started our service on lymphedema and supermicrosurgery. Do you think there would be any chance or opportunity for us to come for
of course.
LVA?
Of course. LVA has become very common in Japanese institutions, and we are open to come to our hospital and learn from us in the operating room directly. So anytime you want, I have more than 100 LVA cases in a year. So every week I do this operation. Please come anytime you want.
Yeah, thank you, Dr. Akita. Last question. Another research that is interesting is the keloid yeah, keloid research, yeah, because we see many patients, keloid patients in Indonesia, and I know that Japan is one of the leading center in the world, yeah. Do you see an opportunity to for a research project perhaps in keloid or scar biology?
Yeah. Actually, I'm very interested in the human population differences of keloids. So, if you want, please collaborate with us to joint research between Japanese and Indonesia populations. I think the same pathology. Especially the molecular piezo2 I made in presentation, but we should investigate more in the Japanese or other countries and even Africans. So if you can, please collaborate us to investigate it.
Yeah.
Thanks so much.
Yeah, and also I think I can also bring Dr. Ridwan into this. Yeah, looking at keloid and scar research, where do you think biomedical engineering could contribute? Yeah, maybe imaging, tissue characterization.
Yes, last time we have sodium excess in dermis to predict by using not only EIT but the only electrode itself. So because the keloid can be specified by our eyes directly. Yeah, we can just put the electrode at that area, and then we can try to identify or try to explore what kind of extraction that we want to study. And it's very interesting because, as I sent email before to Dr. Akita, that it's very possible to make a study program. Not study program, research together regarding to collect the population between Japan and also Indonesia, and then we can compare and identify the characteristic of each human race. So we can compare what's Japan characteristic and Indonesian characteristic, and we can provide a collaboration for the publication. Yeah. I think it's good, but
Yeah,
for the
visible.
imaging, because it's not so volumetric analysis, I think by camera it's enough.
By camera.
Yeah.
What kind of camera? Near infrared camera? Or?
Yeah, kind of near infrared camera. If you want to take a look at the inside keloid, maybe based on impedance or ultrasonograph, maybe. Yeah, maybe. Yeah.
So there are still many opportunities to explore that field. Yeah. Okay. Any more questions? Yes, please.
Okay, thank you. Hi, I am Dina. I am from Forensic and Medical Legal Department. I'm not from Surgery Department, so I'm not going to invading or bothering your fields. But I really want to know your perspective about. I have two questions, Doctor. The first question is about with the increasing collaboration between surgeons and biomedical engineer in developing innovative medical devices. How should professional and legal responsibility be defined if devices-related complication ever occur during the clinical practice? And my second question is about global ethical standards. So, as we know, the system between Japan and Indonesia is having their different kinds of healthcare system, right? So do you believe there should be universal ethical standards for implementing surgical innovation, or should ethical decision making be adapted to local culture itself? Okay, thank you.
Okay, thank you very much for your question. I think you both can answer those questions here. The first question is about the legal aspect of device-related complications. Dr. Ridwan.
Device-related complication, actually following the complication of the patient. I cannot answer now because I have less experience about this complexity. But some maybe research paper I've read and cited in our project, we can see that the needs of patient and medical doctor is specific, sometimes not versatile. Yeah, our goal want to put the EIT like blood pressure monitoring in our home appliance. But to do that, to go to that direction, we still deal with several steps. Yeah, the complication device following the complication of patient, but complication of patient depend on the decision staging from the medical doctor. So that's why it's not a simple way to answer. Yeah, to be honest. But and the second one, for the legal, for ethics, global ethics, very difficult because the stakeholder in our country is under the Ministry of Health. So yeah, only the stakeholder can answer this. Yeah, for us as a researcher, maybe very agree. It's very easy to handle with the global ethics. We can handle research more border, and we can collaborate past borderline. So it's very, I think it's very advanced for us. Yeah, it's a good opportunity for developing the research with the global ethical. But for the decision, ask the chemistry and the ministry.
How do you think?
Yeah, in Japan, ethical committee is very strictly protect the safety of the patients. So we should start with small animals, large animals, and human, and we should prepare the insurance for the patients. So we should need a large budget to perform clinical trials. So, but of course, the benefit of the patient is the most important. So we should step by step make the trials and make patients good results. So what you said is very important. Thank you.
Maybe one additional answer. Sure. Yeah, I want to add an additional answer, but one opportunity specifically for education, not for the clinical process. We have digital twins process for the clinical assessment. Digital twins actually we create kind of meta words that can update it based on the sensor that we use in hospital and update it into meta words. So for example, when we want to maintain the flow of blood, from the real sensor, and we can combine with the other modality, and we combine it in digital metaverse, not in the real clinical assessment. So based on this digital twin, we can modify whatever we want, and there is no ethic, I guess. Yeah.
Any more follow-up questions? That's enough, okay. Any more questions from the floor? Yes, please. This is Dr. Kania, one of our plastic surgery residents.
Thank you for the opportunity. I would like to ask a question to Associate Professor. Regarding your surgery with the endoscopic assisted LD flap, what are the ideal candidates for this? Are only patients with nipple-sparing mastectomy or skin expanders are the ideal candidate, or would you recommend it to other mastectomy patients? Thank you very much.
The most suitable application for this method is relatively fatty and relatively small breast. And in the patient with nipples-spanning mastectomy or tissue expander patients, both can be indicated, but after the radiotherapy conserving breast conserving surgery, the skin is very hard and is shrinking. So after radiotherapy, endoscopy assisted LD flap cannot be indicated because the reconstructed breast will reduce the volume year and year. So after radiotherapy, we don't indicate this method. Thanks so much.
Any more follow-up questions, Dr. Kania? No? Okay. Any more questions from the floor? Maybe the last questions. If not, then I'll ask Dr. Akita and Dr. Ridwan. So regarding the advances in biomedical engineering and technology, what do you see us in the next 10 years or 15 years, let's say?
I think because Japan is a very elderly country, so the most our problem in this plastic surgery area is chronic ulcer on the foot, or diabetic ulcer, or elderly ulcer. This area, regenerative biology is very developing, but we cannot have a complete solution. So using biology and engineering, we should rescue more chronic ulcer patients. But this is a area very difficult and very competitive. So we have not find the solution, but I'm very interested in this area.
What do you think, Dr. Ridwan? 10 to 15 years, 20 years?
Yeah, because I saw my wife study about epigenetics. So I think currently we have summarized. We can summarize our a lot of data of human, for example, genetics, RNA, mRNA, and the behavior, the phenomena, physiology as well, into one CD-ROM maybe, or one single hard disk as a human data. So in the future, I think human can re-engineer the genetic to avoid kind of disease, for example, cancer, not only from the baby, from the how can I say, before baby, yeah, from the fetus, yeah. But maybe later, yeah, the drug discovery will cover genetically how to cure cancer. Yeah, so it's not, currently we study about the drug discovery by using deep learning in our lab with pharmacy. But it's still a very, very long way to get the goal. But genetic engineering will be very, very interesting for the future. I think maybe 20 years later, we can remaster this genetics, how to how to create superhuman, for example, that robust for a lot of disease.
Yeah, let's hope that the advances of the technology would only perform for the good of the patients, yeah, because it's very, very advanced and it can be very wild as well. Yeah, okay. Thank you very much. I think, fortunately, I think we can continue this discussion much longer, but we have reached the time limit of the academic session. If I may take one message from this morning. So the future of reconstructive surgery will not be built by surgeons working alone. Today we have seen how clinical experience, microsurgery, imaging, biomedical engineering, and innovation in technology can come together around one common purpose: to improve the care of our patients. We began this morning with one word, bridging. bridging surgery and engineering, bridging clinical problems and technological solution, and perhaps more importantly, bridging people and institutions. Again, thank you, Dr. Akita, for traveling to Yogyakarta and sharing your knowledge, experience, and time so generously with us. Also, Dr. Ridwan, thank you very much for bringing the biomedical engineering perspective into today's discussion, and thank you to all professor, colleagues, residents, students, and participants joining us online. We hope that today is not the end of the discussion, but beginning the next chapter of collaboration between Chiba University and Universitas Gadjah Mada. Ladies and gentlemen, please join me once again in giving applause for the speakers. Thank you very much, and I will now return the program to Dr. Lily.
Thank you, Dr. Adit. Once again, please give applause for our speakers and also moderators for today. This is really, really interesting discussion. And we invite all of the speakers and all moderators to stand up because we have a token of appreciation for the speaker. And we invite Dr. Rianto to give the token of appreciation from plastic surgery, and also Dr. Siti Syawahdini to stand up and giving the token of appreciation. I also invite Dr. Dila to come forward to take a photo together as well and give the appreciation to the speakers. Okay, the first one is a token appreciation for Associate Professor Shinsuke Akita, M.D., Ph.D. from Chiba University, Graduate School of Medicine, Japan. We are really thankful that and feeling honored that you want to come to Yogyakarta, far away from Japan. Let's take a photo together. One, two, smile. Again, smile. Thank you. Giving applause. Let's give applause a bit. Don't hold it. And then the second one. Thank you to Engineer Ridwan Wicaksono, Bachelor of Engineering, Master of Engineering, Ph.D. from the Department of Electrical Engineering, Faculty of Engineering, Universitas Gadjah Mada, for coming and giving your insight, especially in biomedical engineering. Okay, smile again. Okay, and then we invite all the guests to take a photo together. We invite all the participants today and audience to come forward, and let's take a photo together before we continue to the next one. Oh, okay, kembali. Dibalik aja ke sana gitu. Oh iya. Oh, just come forward and filling the first and second row seat, yeah. Just come forward. You don't have to come to the stage. Just like come closer, so we can take a good picture from this view. Maybe some of you from the right side can move toward this side and move to the center, please. Please come closer. We don't bite, so don't be scared. Come closer, come closer. Oh, iya. Lebih dekat ke sini, ke tengah. Yang row nomor 2 boleh duduk biar terlihat. Yang sebelah kanan terlalu penuh, mungkin beberapa bisa pindah ke sebelah kiri sini. Yang bagian belakang mungkin biar terlihat semua. Okay, ready? 1, 2, smile. Okay, another phone first. Okay.
1, 2, 3, and 1, 2, 3. Any pose, maybe?
UGM pose.
Yes.
Okay, thank you, and give applause for all of us for successfully doing this event today. And thank you for all the speakers, the moderators today, Dr. Aditya Wicaksana, also all the guests and all the audiences for today's event. And also, thank you so much for everyone attending from Zoom meeting, via Zoom meeting and also YouTube to join. And because it's already 12:05, we are going to proceed to the next event, which is mingling with all the speakers today and also all the attendants today while having lunch. So we invite all the attendees here to go towards the front of this hall because we already have lunch for you and you can eat it here or maybe you can bring it. So we are going to have like about an hour to have mingling and also have discussion here. Thank you.